Hello and welcome to the GUMS DKHI Systems Cardiovascular Review lecture. This lecture, if you've looked at the PDF of it, there's loads and loads and loads of slides, but the majority of them are just pictures that we'll go through very quickly. And ultimately, when you're looking through this lecture, there are timestamps in the description, so you can jump around to whatever topic you feel least comfortable with, or wherever you want to have a little bit of revision. So the content of this lecture, we'll go over a bit of physiology review, but I recommend you go back to the ISM review lecture where we did sort of a detailed overview of cardiac physiology. We'll cover some investigations, the high yield conditions revolving around all aspects of the heart, from blood supply to structure to rhythms, and then we'll add on diabetes, which is actually a copy from my year 2 end of year lecture. It might be a little bit too high level at the moment, but I think it's just good to have it there, so in case any diabetes stuff comes up in your MCQ exam or future OSCEs, you've at least heard about some of these concepts now. And then we'll go over cardiac pharmacology and tie it all together with a couple of clinical cases that give you some context for where cardiology fits into diagnosis. If you're low on time, you can just skip to the conditions. The portion covering investigations and stuff is probably not that relevant to the exam at this stage, so you can skip that for now if you want to. But it may be useful for OSCEs and it will be useful for clinical exams later on. So you can return to this lecture in later years if you want, or if you've got time, you can just watch the whole thing. And my advice is cardiology is the most simple, complex specialty, in the sense that it's complex because obviously it's hard to be a cardiologist, but it's simple in the sense that the heart is a pump. And all you really need to understand is preload, contractility, afterload, the RAS system, and then a bit about lipids and blood clots, and then valves and rhythms. And if you put all that together, you actually can understand everything in cardiology. There's a lot less of the specific hormones and factors and things that go into other specialties like gastroenterology or whatever. Study your anatomy, because even though you've done your anatomy exam, they can still put multi-choice questions in, especially cardiac multi-choice questions to do with ECG, the anatomy of the heart related to ECG, and blood vessels and trauma to the chest, what ventricle would be damaged in a sternal stab, and study pathology, of course. Vinod's lecture slides are great. So let's begin with physiology. As I said, you should review the ISM review lecture, and I've put a link here to that. And also this website, CV Physiology, is great if you ever want to look up stuff. I always go back to it just to revise the RAS system and things like that. It's just a really good, nice website. So the cardiac cycle, it refers to the mechanical events occurring in the heart. And it begins basically focusing on the ventricle, where the heart chamber relaxes and then it fills and then it contracts, and then that contraction squeezes the blood out, and so it becomes empty. And there's this term isovolumetric contraction, which I never really understood until I eventually understood it, where the heart fibers are rearranging themselves to generate force, but it's not actually enough force to displace the blood volume. So there's no movement of volume, so that's why it's isovolumetric, but the muscle is contracting during that phase. It's actually the phase where the most ATP is used in the heart. That's a fun trivia fact. The heart valves, they operate based on pressure gradients, so if the pressure in the ventricle is lower than that in the atrium, then the atrioventricular valve will open and blood will flow from the atrium down into the low pressure ventricle, and that's what happens during ventricular diastole. And then when the ventricle contracts and the ventricular pressure becomes higher than that in the aorta, the aortic valve will open and blood will flow from the high pressure ventricle into the lower pressure aorta. The mechanical cycle is governed by the electrical cycle, which is generated by pacemaker cells, and that travels through the electrical conducting system of the heart. So what you see on an ECG refers to the electricity moving through the heart, and that comes a little bit before the actual physical contraction of the heart. So the mechanics of the heart and the pulse that you feel at the wrist, that's all happening physically, secondary to the electrical rhythms that govern that physical movement. Here's just a diagram going through all of that. It's good to always have this in the back of your head. There could be a simple physiology MCQ relating to this. The electrical cycle is the electrical activity in the heart. It doesn't always mean that there is mechanical activity. So for example, pulseless electrical activity is a thing where you get decoupling of the electrical conduction from the mechanical contraction, and it's a scary thing. Your ECG has waves, but the actual heart is in complete arrest. So the QRS complex isn't the same thing as the ventricle contracting. It's just the electrical activity which will cause ventricular contraction. It comes before the mechanical activity, and that electrical activity is measured on an ECG, while mechanical contraction of the heart is measured via echo or other methodalities. This is just to look at the electrical conduction system. So we start in the SA node and we have our fibers that spread out from there. Buckman's bundle is a little low yield thing. That goes to the AV node, to the bundle of His, to our bundle branches, and then out to the Purkinje fibers, and then the heart wall itself. So from this, you just need to remember basically that the P wave is referring to atrial depolarization, which is basically the SA node firing, and that's why the presence of P waves defines a sinus rhythm, because it tells you the rhythm is coming from the SA node, because that's what the P wave is basically. The Q and R and S is the electricity moving through the bundle of His, the bundle branches, and then up to the free wall of the heart. And then the whole thing repolarizing is the T wave. Here's a pacemaker potential that shows the 4 phases of a pacemaker cell, and all you need to really understand here is that pacemaker cells, they have automaticity, they have a rhythm that they generate on their own and can maintain on their own, and it's basically just because they reach threshold on their own via this funny channel, the IF channel, that then depolarizes the cell, it repolarizes, and then that repolarization returns the cell back to this funny channel where it will eventually bring itself naturally to threshold at a certain rate. This is the action potential in a cardiomyocyte that's actually doing the contraction, and this is a good diagram to have a good idea of because this is where the different anti-arrhythmic drugs will act. So when the cell gets depolarized, the cardiomyocyte reaches a threshold and there's a massive influx of sodium which depolarizes the cell. And then there's an influx of calcium as well, which maintains that depolarization, giving the heart this lengthened out curve. And then repolarization occurs when potassium is moved out of the cell. And then it'll be in a refractory period until the next depolarization can happen. And just remember that there's more sodium outside of the cell and more potassium inside of the cell, and That's why depolarization is the movement of sodium in and repolarization is the movement of potassium out. Valves. So the valves are the things that separate the chambers and the vessels and ensure blood is flowing in the right direction. And there are AV valves and semilunar valves. And the closure of the AV valves is the S1 and the semilunar valves is the S2. And the mitral valve is on the left and the tricuspid valve is on the right. And then you have your aortic and pulmonary valves. During systole, the aortic and pulmonary valves open, and during diastole, the mitral and tricuspid valves open. And obviously anything other than that represents a murmur. This diagram on the right is just something interesting. I think these cardiac MRIs are quite beautiful. That's what these are with these lines. The diagram on the left, bottom left, is a drawing by Leonardo da Vinci where he hypothesized how the aortic valve functions a very long time ago, and he drew these swirls because he figured that basically as blood flows out through the aorta, there'll be turbulent flow which spins within the sinuses of the aortic valve leaflets, you know where the little holes are for the coronary arteries, and that turbulent flow would then close the aortic valve. And this is just an MRI showing you that that's exactly what happens, and he predicted that. And the random low yield fact here is that we think that valves operate based on pressure. So when you have ventricular systole, the aortic valve opens because the ventricular pressure is higher than the aortic, and then as the ventricle relaxes, the pressure drops, and so the aortic pressure is higher than the ventricular, and that pressure differential will then close the aortic valve. But what actually happens in real life is that during ventricular systole, this turbulent flow of blood within the aortic valve sinuses begins to close the aortic valve before diastole even begins. So closure of the aortic valve actually starts during systole, not just diastole when the pressures flip. I think that's just so cool, and it makes a lot of sense because if you had to wait all the way till diastole to actually close the valve, you would have significant regurgitation of blood leaking down from the aorta into the ventricle because the valve is completely open. So this is just something interesting that Leonardo da Vinci predicted, and it's very real on this MRI. Coronary circulation. So there's ostia within those valve sinuses, a left and a right coronary artery from the left and right ostia. The branches of the left that you should know are the LAD and the lateral circumflex, and then they have little sub-branches that you could probably get away without knowing right now. And then the right is the right coronary artery, which has a sinuatrial SA nodal branch, and it gives off the PDA in people that have a right dominant circulation, and then from that you get the AV nodal branch. And this is how a right-sided heart attack can lead to arrhythmias, because it will destroy the blood supply to the SA node, for example. The other point about coronary circulation is that coronary perfusion is greatest during diastole. So tachycardia reduces coronary perfusion because you're spending less time in diastole when you become tachycardic. And also nitrates, they reduce cardiac work by reducing preload through venous vasodilation, but they also do have some vasodilatory effects on these coronary vessels themselves. But that's not actually their main mechanism of action for angina treatment, interestingly. Here's just a diagram of those, which I'm sure you've burned into your mind with your anatomy study. The territories to be aware of, so LAD, the sort of anterior portion of the heart, the circumflex, the lateral part of the heart, the right side cardiac conduction and the sort of right wall of the heart, and then the PDA doing the inferior wall. And these are good ECG leads to know for the patterns of MI. 2,3 AVF you would know really well from a PBL case. And then if you remember V2 to V4, then you've kind of just got the rest as the lateral circumflex. And here's just a diagram tying all that together, that 2, 3 AVF are at the bottom of the heart here. 1 AVL, V5, V6 are on the side here where the lateral circumflex supplies. And V1 to V4 is this anterior surface of the heart, which the LAD supplies. Now this ECG shows something that it's obviously not going to come up on your exam, but for some reason every doctor in the hospital thinks I would know what this is because they think that we learn stuff in medical school. So I just thought I'd mention it. If you look at leads V1, V2, V3, the T wave looks a little bit weird. It's going up and then down, up and then down, up and then down. This is what's called a biphasic T wave, and this is a characteristic ECG finding of a condition called Wellens syndrome. Wellens syndrome occurs when there's critical stenosis of the LAD. This is an ECG showing deep T wave inversion in those same leads, and this is another version of Wellens syndrome. So there are two types. There's the biphasic T wave and there's the deep inverted T wave. And basically what it represents is in this anterior view, which is what those precordial leads are showing, the biphasic or the deep inverted T wave represent stress on the wall of the ventricle caused by a critical occlusion that's not a complete occlusion of the LAD, so critical stenosis. And here's a coronary angiogram showing that there's a stenosis here of the LAD, and then they've done a stent and it's now reperfused. So I just kind of thought that's interesting to tie together, the idea that anatomically there is an LAD which supplies the wall of the heart, and then electrically we have ECG leads to look at that part of the heart. We look at the T wave and we think it looks weird in those leads. We then say, oh, well, even though this person has no symptoms, I'm a bit worried about their ventricle. Let's do an angiogram. And then the angiogram shows us that there was a blockage here that one day could have given them a completely fatal heart attack. And then we pop a little stent in and it's fine now. That's just the cool thing about cardiology. Venous return. So you should just be aware that there's the respiratory, arterial, and skeletal muscle pumps, and then one-way valves within the big veins. The major thing that controls venous return for the heart is your total blood volume. So when the RAS system activates and you get lots of fluid, that improves venous return. Equally, dehydration would reduce venous return. The respiratory pump is when you take a deep breath in, the negative intrathoracic pressure sucks blood up into the inferior vena cava because the diaphragm is there and the vena cava is up in the thorax. The arterial pump is this concept that veins sit right next to arteries, and as the pulse wave goes down an artery, the bulging of the arterial wall squishes the vein next to it, which is kind of basically the same as the skeletal muscle pump, that anything that squishes a vein will help to push blood back up through that vein, because that column of blood will go up through the valves and make its way back to the heart. So the aorta being next to the vena cava does this. It's very interesting. And then skeletal muscles, so your calf muscles, your soleus is like the peripheral heart of the body. It circulates blood from your lower limbs back up to your chest. The Frank-Starling mechanism you should be aware of. So when the heart is given more preload, contractility increases. So whatever blood gets sent to the heart will pump back. On the left we have a frog, and in the middle we have Frank and Starling, and on the right we have their curve. Chronotropes, inotropes, dromotropes. Dromotropes you wouldn't have heard of. Chronotropes Chrono, meaning time. Chronotropes are to do with heart rate, and they can be positive or negative. Positive increase, negative decrease. Positive chronotrope would be something like noradrenaline, which acts on beta-1 receptors to increase heart rate. Negative chronotropes would be beta blockers. Inotropes are the same thing but for contractility, positive and negative. Dromotropes are the same thing, but they're to do with conduction, especially over the AV node. So these are drugs that reduce the actual conduction of the depolarization down through the AV node. Drugs that are like amiodarone and certain calcium channel blockers that are anti-arrhythmics. Blood pressure. I'm sure you know this so well at this point, but start off with the equation of mean arterial pressure equals cardiac output times TPR, and then break cardiac output into heart rate and stroke volume, and then take those three things and try and figure out how do they work. Heart rate. Heart rate is controlled by the parasympathetic and sympathetic nervous systems, either muscarinic receptors to slow the heart down, or beta-1 receptors to speed it up and make it contract harder. Stroke volume. Stroke volume is the difference between the diastolic full volume and the systolic empty volume. The amount of time you spend in diastole means you've got more diastolic volume, and then via Frank-Starling you'll have a greater stroke volume because you'll have higher contractility. And so increased venous return will increase end diastolic volume, which will stretch the heart, which will cause the Frank-Starling mechanism, which will increase stroke volume. So that's how venous return affects cardiac output, by increasing stroke volume. And so when RAS modulates your blood volume through aldosterone, that's how it can increase your cardiac output to increase your blood pressure, or at least one mechanism. Total peripheral resistance is the amount of vasoconstriction or dilation in your peripheral arterioles, and angiotensin II causes vasoconstriction, and so do the catecholamines on alpha-1 receptors. I'm sure you know this really well now, that there's baroreceptors and there's a brain that integrates all of it and then sends those signals out to neurologically control blood pressure in the short term. There's basically neurological and endocrine effects working together to maintain blood pressure. Here's a diagram of the RAS system. So when the kidney gets stimulated by catecholamines directly by the sympathetic nervous system, or peripherally by circulating catecholamines through the beta-1 receptors, or senses a decreased blood pressure at the baroreceptors in the afferent arteriole, or that there's decreased sodium delivery to the distal tubule, which is a sort of surrogate marker for GFR, because if there's more filtrate, there'll be more sodium. So if there's less filtrate, there'll be less sodium. All of those things are the three triggers that make the kidney release renin, and then renin through angiotensinogen will form angiotensin 1. So renin is the enzyme that does that cleavage. And then angiotensin 1 circulates to the lungs, where ACE converts it to angiotensin 2, where it then causes peripheral vasoconstriction to increase blood pressure, but also goes to the brain and adrenal cortex to cause the release of ADH and aldosterone, which cause fluid retention to increase blood volume. So those things together will both increase your blood volume, which will increase your stroke volume, and increase your peripheral resistance. So you've got an increase in cardiac output and peripheral resistance, which together will increase your mean arterial pressure. And here's just an anatomical diagram to show you where all these things are coming from. The thing to take away from all of this is that it's a dynamic thing, and if you've got more volume, there'll be more venous return, which means there's a greater end diastolic volume, and then via Frank-Starling there'll be more contractility, and so you'll have a greater stroke volume, which means you've got more cardiac output and more mean arterial pressure. So you need to sort of break it up in terms of stroke volume, which depends on, how much fluid is in the heart and how hard the heart's squeezing on that fluid, which is both the Frank-Starling effect and the effect of hormones like adrenaline and noradrenaline and positive inotropic medications like digoxin or whatever, the heart rate, and then the total peripheral resistance. And if you tie all these things together, you can understand how blood pressure pharmacology works. We have drugs that control the heart rate, the peripheral resistance, and also the stroke volume indirectly in terms of diuretics and ACE inhibitors preventing the release of aldosterone. Okay, let's quickly talk about pathology. I'm not going to teach it to you, but you should go and review the cardiac topics like atherosclerosis and myocardial infarction, myocardial necrosis. You should know the steps for atherosclerosis and just be able to identify these things on slides. And on the right, we have a very clear picture showing a moderately differentiated grade 3 adenocarcinoma of the prostate with localized invasion through the basement membrane and associated desmoplasia of the nearby connective tissue. Not really, it's just some purple and pink, like all of histology. Let's quickly go over some cardiac investigations from ECG to chest X-ray to echo and cardiac biomarkers. So firstly, let's go over the biomarkers. The one you care about is cardiac troponin. Cardiac troponin will be detectable about 4 hours after myocardial injury, and it will persist for about 10 days after the event. The serial troponins are measured at admission and then 6 hours later, and they'll be positive in an N-STEMI and a STEMI, which are the sort of two on the far end of the acute coronary syndrome. They will be negative in unstable angina, as we'll talk about later. The troponin elevation can actually be neurogenic from a stroke, so it doesn't have to be like an actual heart attack, and it can also be chronically raised in renal failure. And also it can occasionally leak during heart failure. So it's not perfect, but in someone with symptoms of chest pain with ST elevation and a rise of troponin on serial troponins, that's 100% a STEMI. The B type, previously called brain type, natriuretic peptide, that will be elevated in congestive heart failure, and it's highly sensitive for congestive heart failure. And it's because in heart failure you have stretch of the atria because there's the backup of blood from the failing ventricles, and so that's something you can test for to detect heart failure. ECGs, there's kind of two purposes to them. One is to detect ischemic change, and the other one is to detect rhythmic change. So you already know all of this about ischemia, the different STEMIs, the different blood vessels, and the different leads. I personally just remember the 2-3 AVF, and then I think about the front of the heart, and I go, yep, it's roughly V2 to V4. And then I say, well, what's left? There's lead 1, because 2 and 3 were taken. There's AVL, because AVF was taken and AVR is not relevant. And then we have the leads that are on the left side of the chest, V5 and V6. That's sort of, as long as you can at least remember 2-3 AVF, you can guess what the other ones are if it's a stroke in different leads. So let's look at this stroke. There's ST segment elevation in V2, V3, and probably V4 and V1. So this is an anterior STEMI, but there's also ST elevation in lead 1, AVL, and a little bit there in V6. V5 is kind of unclear. So this is probably what we'd call an anterolateral STEMI, where there's the left anterior descending artery as well as a bit of the left circumflex artery, because there's probably an occlusion somewhere along the left coronary artery before both of them branch off. The way that you can prove to yourself that this is real is that there's reciprocal depression in 2, 3, and AVF. So because this is a sort of anterior lateral portion of the heart ischemia, the opposite side of the heart would be the inferior portion of the heart, and so that has the opposite change. In 2, 3, and AVF, there's ST depression. So this is an anterolateral STEMI. In terms of rhythms, the ones that you should at least have a rough idea of, and honestly, if you're in an OSCE station or something, they'll probably just show you a normal ECG and ask you to interpret it, which you need to make sure you can do systematically. So the first thing you should do is check for the patient's name, date of birth, and the indication for the ECG. You should then look at the rate, rhythm, and axis, and then look at the waves from left to right, P, PR, QRS, QT, T, U. And as long as you do that, you'll be fine. So bradyarrhythmias, so low heart rate arrhythmias, you could have sinus bradycardia, someone who's just very fit and their heart rate is low at rest. You could have a junctional rhythm, which is when the heart rate is actually coming from the bundle of His. So it's a slow heart rate from 40 to 60, and the QRS looks like a normal QRS, but there's no P waves. Or you could have a rhythm coming from the ventricle, where it would be a wide QRS because it's being poorly conducted through the actual ventricle. It'd be a very slow rhythm of 20 to 40, and it's also known as a ventricular escape rhythm. You've got first, second, and third degree heart block, which we'll talk about in a second. And then you've got the fast arrhythmias. So AF, A-flutter, SVT, and VT. AF doesn't have to be fast. It's just there's specifically AF with rapid ventricular rate, RVR. You could have slow AF as well. SVT versus VT is important to differentiate because the management of SVT is quite different from VT. VT is a life-threatening, pulseless VT is the one that you need to defibrillate because it can become ventricular fibrillation and then cardiac arrest, basically. So let's look at some ECGs. Junctional rhythm, there's no P wave. Or if there is a P wave, it's a retrograde P wave, which is basically the QRS is beginning at the bundle of His and a little bit of electricity is going up into the atrium, which means there'll be a tiny little fake P wave, but the actual QRS-T just looks normal and the rate is slow. Here we have a ventricular rhythm. So the QRS is very wide, doesn't look like a normal QRS, and there's no P waves. So this is a ventricular escape rhythm. Heart blocks. First degree heart block, you look at the PR interval, which is from the beginning of the P wave to the beginning of the Q wave. And if that's greater than 200 milliseconds, which is one big box, that's first degree heart block if it stays constant. Okay, so first degree heart block, all there is just a long PR interval, which is constant, but every single beat is conducted. The difference between first degree and second degree is that in second degree, every so often a heartbeat doesn't get conducted. And then within that, there's two types. There's the second degree type 1, or Mobitz 1, or Wenckebach, where the PR interval gets progressively longer and then a heartbeat is dropped. There's no QRS. And then it resets and goes again. And then there's type 2 or Mobitz 2 where the PR interval is constant but a heartbeat gets dropped. But there's a P wave. Okay? And then this 2-1 block doesn't really matter, but there's just this extra one that there's 2 P waves and then a heartbeat, 2 P waves and then a heartbeat. Third degree heart block is when the AV node and the ventricle have nothing to do with each other, or the SA node, sorry. And so there's P waves firing at their own pacemaker rate, and then there's ventricular waves firing at a separate pacemaker rate. So the PP interval will be constant and the RR interval will be constant, but the P's and the QRS's are completely separated. There's no coordination between them. Because the ventricular rhythm is coming from the ventricle, it'll have a wide QRS morphology, kind of like the ventricular escape. In third degree heart block, what you're basically getting is a normal atrial rate with P waves that are regular, and then regular ventricular escape rhythm QRS beats. So that's what's shown here. Okay. So type 1 in first degree heart block is just a long PR. Second degree, you drop beats. Type 1, it gets progressively longer. Type 2, it remains constant. And then third degree heart block, they're completely disconnected, and the ventricular morphology is a wide QRS. This is an ECG that I hope is making sense now. Let's interpret this ECG like it's a real one. So it doesn't have a patient name, it doesn't have their date of birth, and it doesn't have an indication. The heart rate. Well, I've realized that the RR interval is changing, so I can't really just use, there are a couple of different rules, like you take 300 divided by the number of big boxes. So right here, the heart rate is 150 because there's 2 big boxes. But then we look at another one and there's 3 big boxes, and then there's 3.5 to 4. So what you have to do in this irregular heartbeat is actually count the number of QRSs in a 10-second strip and times it by 6. Or, however long the strip is to get you a minute worth of QRSs. Okay, so the rate is, it ranges from 150 to 80, 60-ish. Okay, so it's fast. The rhythm. Do you see P waves? You see a lot of different kinds of waves, but if you look at each QRS complex, there's no obvious looking P wave, especially on this first one. There's just a flat line and then a QRS. So it's not sinus, because sinus refers to the fact that there's P waves. Then you look at the RR interval. It's irregular. So this is a non-sinus arrhythmia. The irregularity in the RR interval is completely random. So it's irregularly irregular. There are other arrhythmias where, for example, every third beat will look weird. That would be a regularly irregular arrhythmia. Whereas this one, the RR interval is random. So it's an irregularly irregular arrhythmia. Axis, lead 1 is it's positive, just barely, and then AVF is really positive. So we'll call that a normal axis, but there's a chance that there's going to be some right axis deviation one day. So that's rate, rhythm, and axis. P waves, there are none. PR interval, you can't calculate it because there's no P waves. QRS, the QRS is a little bit wide, but it's not too bad. So a wide QRS would be more than 3 little squares, 120 milliseconds, which this one's just about 3 little squares. QT interval, that shouldn't be more than 420 milliseconds, which the machine will tell you that. A basic rule of thumb is that the QT interval shouldn't be more than half of the RR interval. And then you look at T waves, there's no sort of scary looking T waves or ST segment elevation or depression. So this is an ECG of atrial fibrillation. This is atrial flutter with a 3-to-1 block, where you've got 1, 2, 3 flutter waves for every QRS. This is SVT, supraventricular tachycardia. So it's a tachycardia with a narrow QRS. That's all you need to really know for differentiating VT from SVT at this stage, is that SVT is a narrow QRS tachycardia. Whereas this is a wide QRS or broad complex tachycardia, this is ventricular tachycardia. So SVT, because the tachycardia is arising from above the ventricle, it's supraventricular, the QRS is being conducted through the normal conduction system. It's just being done so at a very fast rate. So the QRS morphology looks normal. Ventricular tachycardia, the tachycardia is coming from the ventricle itself. So it has that wide ventricular pattern of conduction. So this is VT. This is torsades, which is a form of polymorphic VT associated with long QT syndrome. And this can very quickly degenerate into ventricular fibrillation. What basically happens is that people with long QT syndrome, if during that long period of repolarization you get a ectopic from a ventricular ectopic, the sort of R on T phenomenon, they call it, will cause the heart to degenerate into this polymorphic VT known as torsades. You don't need to know this, but just quickly, left bundle branch block and right bundle branch block. So you look at leads V1 and V6. In left bundle branch block, there'll be a wide QRS, and V1 will be going down, and V6 will be going up, and it'll typically be notched. And it kind of looks like an M. Right bundle branch block is the opposite, where it still has this sort of wide QRS, but V1 will be positive in its R wave, and it may form this RSR complex, which looks like little bunny ears. And then V6 won't have that M morphology. You don't need to really know this at this level, but bundle branch blocks come up in every ECG. Right bundle branch block is very common and it can be pretty normal. But a new onset left bundle branch block is very scary, and it suggests someone's having a myocardial infarction. Let's quickly talk through chest x-rays in the context of cardiology. So interpreting a normal chest x-ray is a really important potential OSCE station. So firstly, as always, you look for the patient's name, their date of birth, and the reason why they got the chest x-ray. And then you assess the quality of the x-ray. So RIPE is a good acronym of rotation, inspiration, position, and exposure. So for rotation, we're checking that the clavicles look sort of, horizontal, and that the relative to the trachea, there's no obvious rotation of the shoulders. And you can also look at the positions of the scapulae. Assessing inspiration, you want to be able to see enough space in between each rib, and you want to see enough posterior and anterior ribs. There's a specific number, but you could kind of just make it up, say that it's appropriate inspiration, or you could say it's a poor inspiratory effort. The position, so you want to be able to see below both diaphragms and above both shoulders. And exposure, you want to see, a couple of the thoracic rib spinous processes, but you don't want to be seeing like lumbar spinous processes in terms of how penetrating the x-rays are. Then you want to look at the actual x-ray. And at our level, you can just remember A, B, C, D, E. A, airway, look at the trachea. Is it midline or not? B, breathing, look at the lung fields. Upper, middle, and lower zones. So we refer to zones rather than lobes on radiology because you're not actually looking at the anatomy, you're just looking at, dividing your screen into thirds and then looking within each zone. The costophrenic angle. the cardiophrenic angle, and then the lung hilums, especially for lymphadenopathy, sarcoidosis, signs of infection around the airways. Cardiac, look for the cardiac silhouette, look for in case there's left atrial enlargement, check that the cardiothoracic ratio is less than half, so the heart relative to the chest is only half of the chest in terms of its width. Look at the mediastinum in case it's enlarged in something like aortic dissection or aortic aneurysm if it's a aortic root aneurysm. And then look at the knuckles of the vessels. Look at the diaphragms. Are they flattened? Is there a pleural effusion? Are they raised? Is there cancer on the diaphragm? And then extras. So look at the ribs for rib fractures, gastric bubble, soft tissues for soft tissue emphysema, tubes, devices, ECG leads, pacemakers, whatever. When I was on my GP placement in second year, the GP showed me an X-ray, and I spent all this time looking through it, and I was like, yeah, I guess sort of there might be some consolidation of the right sort of middle zone of this X-ray. And then he goes, have a look at the ribs. And like there were 7 rib fractures in a row, and I didn't see it because I wasn't looking for it. So it's good to remember this extras one to, it's an X-ray. Look at the bones. It's the perfect imaging for bones. And then give your overall impression and diagnosis. This radiology masterclass tutorial is the perfect thing to just go through at least once before your OSCEs to, have a good grip on how to do chest x-rays, because it's a skill that you need, and radiologists don't actually report on all of them. It'll be you that sees it first and has to make a decision, even as an intern. Except obviously there's always someone there to support you when you're an intern, so don't take that to be something scary. It's just they'll expect you to be able to say whether or not there's a pneumothorax or something. Here's the normal anatomy on X-ray. So the trachea, midline, relative to the spinous processes and the clavicles, lung fields, cardiac silhouette, diaphragm, extras. And here's it from the side. I'm not so good with the lateral view, but basically the best thing it's for is to evaluate a pleural effusion from the side, because you can't always appreciate it that well from the front. And also pneumonia, like if you think there's like a right middle lobe pneumonia, you could be confusing it for a sort of inferior lobe pneumonia. So when you look at the lateral view, then you can divide it up really well, and you can know for sure that it's definitely the middle lobe. Let's look at this X-ray. So if we interpret this X-ray, it doesn't look malrotated. There's a good inspiratory effort. The position allows us to see everything. The exposure might be a little bit funny because you can't really see the spinous processes that far down. In terms of the airway, it's in the middle, roughly. Again, can't see too well. Lung fields go all the way to the edges. The crostophrenic angles are there, maybe a little bit blunted. But the main thing you're looking at here is the heart. The cardiothoracic ratio relative to the chest, this is a big heart. This is a cardiomegaly X-ray. So the features you can see there are the double shadow of the heart because of the enlargement of the atrium. You can see both lines, whereas normally all you can see is the right atrium. You're now also seeing the left atrium enlarged behind the right atrium. And the angle of the carina, or the subcarinal angle, is becoming more obtuse because the enlarged left atrium is pushing up against it, making it be more obtuse when normally it's more acute. And here's the cardiothoracic ratio. So this is a cardiomegaly X-ray. There are many causes of cardiomegaly, dilated cardiomyopathy, heart failure, hypertension, congenital defects, etc. Heart failure is another good chest X-ray to understand, and it's got its own system of A, B, C, D, E with alveolar edema, with those sort of air bronchograms and things, curly B lines, cardiomegaly, dilation of the upper lobe vessels, or what we call cephalization or cephalization of vasculature, and pleural effusions associated with all of that pulmonary edema. The blue lines here are the curly B lines, so they're in the periphery, they're horizontal lines, and they represent fluid collection in the interlobular septa of the lungs. So that represents pulmonary edema, basically. Here we can see that there's cardiomegaly. The horizontal fissure on the right side is a bit radio-opaque here, suggesting that there's some pleural effusion there. So this is a heart failure chest X-ray. And that's highlighted here. So the pleural effusion, the vasculature being visible at the top of the lung, curly B lines, and the cardiothoracic ratio being enlarged. Have a look at this chest X-ray. Does it look normal? No, it doesn't. So if you look at the mediastinum, it's enormous. So this is an aortic dissection. This is a boot-shaped heart. It's a spot diagnosis for tetralogy of Fallot. Echo. You don't need to know anything about echo, but I just want you to understand that, where ECGs evaluate the electrical heart, echoes evaluate the structural and functional heart. And you can do lots with echo. There's two types, a TTE and a TOE. The transthoracic echo, the TTE, is easy to perform, can be done very quickly. It's just holding a probe up to your chest. You can evaluate ejection fraction for heart failure. You can look at the size of the chambers of the heart to see if they're dilated, and you can basically assess the valves, but not as clearly as with a TOE. A transesophageal echo, or TOE, has a higher resolution because it's physically closer to the heart, and it doesn't have all that chest wall in the way. It's got a better sensitivity for endocarditis, so if you suspect endocarditis, you need a TOE. It's really good for clots, so if someone's had a stroke and they have AF, you should get them a TOE to see if there's a big left atrial thrombus or something that's led to their cardioembolic stroke. It's good for assessing the aorta and valves in more detail compared to the TTE. This is an echo showing bicuspid aortic valve with the fusion of the two leaflets here with a RAF or raphe. So normally there would be 3 leaflets here of the tricuspid valve, but there's just 2 here. This is bicuspid aortic valve.
Alrighty guys, my name's Hamish. I'll be taking you through some cardiovascular conditions. So to start with, I'll be talking about ischemic heart disease, or IHD. So ischemic heart disease, essentially, it represents a group of syndromes resulting from myocardial infarction. And essentially the key here is that it's caused from a dysregulation of supply and demand of oxygen and other nutrients. So pretty much because either you have too much demand or not enough supply, you're creating a hypoxic and a really toxic environment for the myocardium. And so you're actually going to get myocardial cell death, which is the end result of ischemic heart disease. So in terms of etiology, the most common cause is coronary heart disease. So essentially you can imagine like ischemic heart disease is an umbrella term which is caused by a variety of different diseases. And the most common one is coronary heart disease, and it causes about 90% of ischemic heart disease. So essentially coronary heart disease is an atherosclerotic process, and it results in an atheroma forming. And I will talk a little bit about both of these processes in a minute. But for coronary heart disease, I just want you to remember it's pretty much an atherosclerotic process. And coronary heart disease essentially exists on a spectrum, which includes stable angina and acute coronary syndrome, which we'll discuss later as well. So in terms of specifically looking at the etiology of ischemic heart disease, as I mentioned, there's either a decreased supply in oxygen to the heart, or there's an increased demand in the heart has to pump harder to overcome something. So examples for decreased supply include coronary artery disease, as we were just talking about, because obviously an atherosclerotic process or an atheroma forming is going to reduce the amount of blood supply to the heart, causing ischemic heart disease. You can also have thrombosis, spasms, an embolus, and also anemia, which can cause decreased supply of oxygen to the heart. Increased demand is stuff like sort of outside of the heart. So you've got your hypertension, your diabetes. Anemia actually can cause both as well, which is an interesting concept. But essentially, it's things that are outside of the heart that are causing it to work harder. So I've given you a little bit of a list here. In terms of the complications of ischemic heart disease, as I mentioned before, it exists essentially on a spectrum where it's similar to acute coronary syndrome. And the spectrum sort of moves up and down depending on where you are and what sort of treatment you're getting. But at the end of the spectrum is stable angina. So this is where, and we'll talk a little bit about angina in a minute, but this is essentially where you're getting some cardiac pain upon exercise, whereas something like an unstable angina is where you're getting cardiac pain, so heart pain, not just in exercise, but during rest as well. And this exists on a spectrum as well with an NSTEMI, or a non-ST elevated MI, and a STEMI, which Claudia will take you through in a little bit. Ischemic heart disease also causes chronic ischemic heart disease, obviously if this is left untreated for a while, and it can also cause heart failure. So it all exists on that sort of spectrum. In terms of clinical presentation, the main thing you guys need to know, because there's a lot that a patient can present with, but it's angina that you really need to know for your exams and also for clinical medicine. But I really want you to focus on angina, as because chest pain essentially is one of the most common symptom that you'll get with ischemic heart disease. And you also get people presenting with complications that I've talked about above. So a patient could present with an MI, so myocardial infarction, after having ischemic heart disease that they didn't know about for quite some time. In terms of diagnosis, so a patient will be placed into a stable or unstable category depending on the following things that are evaluated. So an ECG is probably the first most important thing to know. And also important to know is cardiac blood markers, so troponins. This is very important for ruling in or ruling out a myocardial infarction. Doing some stress tests, some echocardiography, and some coronary angiography make up some other diagnostic tools. In terms of management, there's really your general management. So you manage the coexisting conditions that could be causing ischemic heart disease. So for example, if you've got hypertension, you want to get on top of that with some medication, which we'll also talk about in a little bit. In terms of what can improve, so it says prognostic there, what can improve prognostic therapies, so sort of improve outcomes, is your aspirin and your lipid-lowering therapies. These are going to improve the prognosis of your ischemic heart disease. In terms of symptomatic treatment, we've got GTN, and that's going to be used for patients who suffer from angina, and so they will take that when they're having severe symptoms. We've also got prophylactic therapy, so you've got your beta blockers, your calcium channel blockers, your nitrate, long-acting nitrates, etc., etc. Those are the kind of things you want to be looking at for ischemic heart disease. And then, of course, we've got stents and bypasses, so CABG. They're sort of interventional therapies, so surgery, that will help to manage ischemic heart disease. So now we're going to be discussing atherosclerosis. So atherosclerosis is defined as a chronic inflammatory and healing process in which it's a response to arterial wall endothelial injury. So as you might remember, found in your arteries, there's a couple of layers. So your tunica intima, this is where you find your endothelial cells. So these are cells that are in direct contact with the blood. So essentially damage to these endothelial cells is what's going to kickstart this atherosclerotic process, which, as I mentioned, is defined as an inflammatory process. And really, atherosclerosis is the key pathology that underlies much of the pathogenesis of cerebral, peripheral, and coronary vascular disease. In a nutshell, it causes blockage of blood flow. And we'll talk about how it does that in a moment. But atherosclerosis, when you think of that, think of blockage of blood flow. So in terms of etiologies, you might remember this from lovely DHC. But you've got non-modifiable and modifiable risk factors that can lead to atherosclerosis. So obviously non-modifiable stuff is your family history, your increasing age, having a male gender, and any genetic abnormalities that you might have. Whereas modifiable risk factors can include hypertension, hyperlipidemia, smoking, diabetes, lack of exercise. You've probably heard all these before. Obesity should be on there as well. So all the kind of general stuff that we need to avoid. Now, I've listed here the steps in atherosclerotic process. Important to note is that this is Griffith's atherosclerotic process steps. It's not necessarily what exactly happens in the real world, but this is something to know for Griffith's exams. So I've listed them here. So obviously you begin with endothelial injury and dysfunction. You get accumulation of your lipoproteins, so your low density lipids, your LDLs. You get monocyte adhesion to the endothelium, so monocytes being your part of your immune system. You then get migration of macrophages to the site, and they start to engulf the LDLs, and they form something called foam cells, which essentially is a fatty macrophage. You then get platelets that adhere to the damaged site, and you start getting factors released from the platelets and macrophages, and these factors recruit smooth muscle cells, and you get proliferation and extracellular matrix deposition by these smooth muscle cells. And essentially this accumulation of LDL lipids and extracellular matrix proteins depositions, they start to accumulate extracellularly and within cells, and you start to get a necrotic core forming. And then finally you get a fibrous cap forming on the top, which sort of protects the atherosclerotic atheroma. So we talk about atherosclerosis and we talk about atheromas, but what on earth do both these terms? Are these terms interrelated? How do they relate together? So I've sort of listed it out here. So atherosclerosis is the pathological process which causes the intimal lesions called atheromas. So all the time previously I was talking about foamy macrophages, I was talking about necrosis, I was talking about LDLs, I was talking about fibrous cap. That makes up your atheroma. So the atheroma is the actual thing that you see in the atherosclerotic process. So it's the outcome of atherosclerosis, essentially. And it should be noted that I've listed 4 things here. So this is your pathology, so with Vinon. These 4 things need to be there for it to be called an atheroma. So you need a fibrous cap, you need foamy macrophages, you need basal zone of necrosis, and you need lipids, so LDLs. And I've listed here, so number 2 is your cholesterol clefts. In that circle, you've got a necrosis, which is full of lipids. You can see it's because it's much more pink than the other sides. You can't see them with foamy macrophages at this scale, but I can assure you they are most likely there. And then finally, number 1, which is that arrow on the left, it's a fibrous cap that's forming. So now we're going to talk a little bit, change tact a little bit and talk about angina. It does relate heavily to atherosclerotic process, which we've discussed previously in our ischemic heart disease section. So angina is the most common symptom of ischemic heart disease. And essentially it is chest pain caused from myocardial ischemia. That's what angina literally means. It is chest pain. Now there's 3 main types of angina that you need to know. There's stable angina, there's unstable angina, which Claudia will talk about in terms of an acute coronary syndrome. And there's something called Prinzmetals, which we'll also discuss in a little bit. So in terms of etiology, it's very similar to ischemic heart disease. You'll notice with all these cardiac conditions, they're all very similar because they're all interrelated. So it's about the increased demand and decreased supply. And I've listed some sort of causes here for angina, but it's very similar to ischemic heart disease. In terms of the pathophys, so pretty much the main thing that, because you can get really lost in here, the main thing that Griffith wants you to know is that the lack of oxygen to cardiomyocytes causes a transfer of metabolism to anaerobic metabolism. And this causes toxic byproducts to be formed and to accumulate. And this irritates the phrenic and vagal nerve endings that are surrounding that are attached directly to your heart and to the pericardium. So there's a couple of definitions, as I mentioned. There's stable angina. This is where you have a stable plaque with pain on exertion. So essentially the only way you can really diagnose this properly is with provocative testing, so you do a stress test. Then you have unstable angina. This is where you usually have an unstable plaque and thrombosis. So thrombosis meaning the forming of a thrombus. And here you get increased pain in its duration and its frequency. So you don't just get it on exertion, you get it at rest too. And finally, there's one that's pretty rare, and it's called Prinzmetals. And it's caused by coronary vasospasm. So I've got a little diagram here at the bottom of the slide. So you've got on the left-hand side in A, you've got stable angina pectoris. That's just stable angina. You can see here you've got this plaque that's not really doing too much. It's just sort of occluding a little bit of the lumen of the blood vessel, but it's not really doing too much. Next to it, in number B, it's unstable angina pectoris. And you can see here that you've started to get quite a large thrombus forming. And you can see here, obviously, that because there's such a large occlusion inside the blood vessel, it's going to cause some more severe symptoms if this was in the heart, for example. And so you can see why unstable angina is much worse than stable angina. And then in C, I've given an example of what a myocardial infarction is, and that's pretty much complete occlusion. It should be noted, though, that we're talking about partial occlusion, complete occlusion. These do exist on a spectrum. It really depends on the coronary artery affected, and it also really depends on the collateral supply of the heart area affected. So just keep that in mind, that these are sort of very general terms. Finally, Prinzmetals, I've got that little diagram on the right. Essentially what happens is you have random coronary spasms where the coronary artery becomes constricted, and it undergoes something called a vasospasm. And they're not really too sure why this happens, but it is a sort of a diagnosis of exclusion. So you need to rule out stable and unstable angina before you can say, oh, it's Prinzmetals. And as I mentioned, it is pretty rare. So in terms of diagnosis, it's similar to ischemic heart disease. So I'd recommend you look at those slides. We're talking about using ECGs, your cardiac markers, so your TROPs, and all that kind of jazz. So next is your management. Again, reoccurring theme, very similar to ischemic heart disease. General management, you want to manage the coexisting conditions that could be exacerbating angina. So, your anemia, your hypertension, your diabetes, etc. You've got prognostic therapies. So this is, again, aspirin and lipid-lowering therapies. So this is going to improve the prognosis of angina. So it's going to mean you're going to get a better outcome. We've got your symptomatic treatment, which is GTN. So again, if a patient has severe angina, we're going to give them GTN to allow that vasodilation. You've got your prophylactic therapy, which again is beta blockers, calcium channel blockers, long-acting nitrates. And finally, your interventional therapy, so your surgery, which is going to be a stent or a bypass, which is going to be put in.
Let's talk about acute coronary syndrome. So the acute coronary syndrome is a spectrum of disease that has one common clinical presentation, but three different etiologies for that presentation. So when you have acute myocardial ischemia progressing to infarction, due to the occlusion of coronary arteries, either being complete or sort of a waxing and waning occlusion, that's when you've entered the acute coronary syndrome territory. So stable angina is when you have ischemic heart disease with, say 70% occlusion of a coronary artery with a stable atheromatous plaque, and the pain is coming from reduced blood flow through that small narrowed artery. These syndromes are when that plaque has ruptured, a clot forms on top of that plaque, and then if the clot is big enough to block the entire coronary vessel, that'll typically be a STEMI. If it, doesn't completely block things, that can be a non-STEMI. And then if it forms a clot and then the clot breaks itself down and then keeps forming and breaking down again and again, that's kind of the waxing and waning picture of unstable angina. The way to differentiate unstable angina from stable angina is that stable angina will be predictable. So, when you exert yourself, you get chest pain. Unstable angina is when even at rest you're getting chest pain. But they all look the same. Essentially, the patient with retrosternal chest pain radiating to the jaw or the arm. It's a crushing sensation in their chest that, it's not to do with moving the muscles or taking deep breaths in and out. They might appear sweaty and quite agitated and fearful for their life with anxiety. But the point is that this is a group of conditions that you can't actually separate them just based on history. So what you need to do is understand, firstly, unstable angina, which is on sort of the left side of the spectrum, where you have partial occlusion of a coronary vessel, and you get ischemic symptoms which are now arising at rest. So minimal exertion at rest. That's the thing that separates this from stable angina. NSTEMI, which is, sort of partial occlusion, compare that to total occlusion in a STEMI, and it only affects the subendocardial myocardium, whereas a STEMI is a transmural infarction. That's not totally true. There's a lot of debate about what an NSTEMI really is, but that's sort of enough of an understanding at our level. And the difference between this and unstable angina is that NSTEMI will have NSTEMI features on the ECG. STEMI is the one that you know really well. So it's a complete occlusion of a coronary artery secondary to clot formation, and that's a full thickness transmural infarction that will present with ST elevation in the relevant leads with reciprocal depression in the opposite leads. So sort of dividing this up into diagnostics, someone comes in with chest pain at rest that appears to be cardiac in nature after taking a bit of a history. You order an ECG and you get serial ECGs every 15 minutes to look for evolution. You take blood and do cardiac troponin, baseline, and then 6 hours later. And that will really give you everything you need. So unstable angina, the troponin will be normal, the ECG will be normal, but they still have the clinical feature of cardiac chest pain at rest. NSTEMI versus STEMI, they'll both have troponin rise, but an NSTEMI will have, either ST depression or some T wave changes that suggest ischemia. STEMI will have ST elevation in contiguous leads with reciprocal depression in the opposite leads. The management of STEMI is where you go hard. So you anticoagulate with antiplatelet drugs as well as heparin, but then you also consider thrombolysis with a drug like, alteplase. Or if you can get there within 90 minutes, you do percutaneous coronary intervention and put in a stent to revascularize that lumen of that occluded coronary artery. Percutaneous coronary intervention is far better than thrombolytic therapy. For every 100 people treated, there will be, say, 2 extra lives saved if you elect to treat everyone with PCI, which, over the 60,000 heart attacks we get in Australia every year, that's hundreds of people that will be saved that otherwise would have died if you didn't elect to do PCI. And in the unstable angina NSTEMI spectrum, here the risk benefit for thrombolysis just isn't there. So you don't do thrombolysis, but you do everything else. So you give antiplatelet drugs, so dual antiplatelets, and also heparin. But you don't do the clot busting therapy. Just to sort of revise again, cardiac biomarkers. So cardiac troponins, they rise sort of 4 hours after the event and they stick around for about 10 days. And CKMB is another one you can use, but cardiac troponin is basically what's done. You do it on admission and then you do it again 6 hours later to look at the trend, as we talked about earlier. Another point about troponin, so the troponin T is very sensitive. Unfortunately, All you really need is to type the word cardiac troponin into IEMR and it'll order everything you need. So that's real life. You can just type the word cardiac and you don't have to even think about which markers do what and when. Okay, so the treatment for STEMI. PCI. PCI is the best if it can be done within 90 minutes. Thrombolytic therapy, as long as they don't have any contraindications such as previous brain bleeds or already being on strong anticoagulation. And then medical therapy with dual antiplatelet therapy, and what's missing from this slide is to also give heparin at a therapeutic dose, so 1 milligram per kilogram twice a day, not just the lower DVT prophylaxis dose, but a full dose of heparin. Unstable or angina or NSTEMI, again, dual antiplatelets, anticoagulation, but typically you won't do an invasive procedure here. They could eventually have an intervention later on. You don't have to be having a heart attack to get stented, but generally speaking, the risk-benefit says that these people can be managed medically rather than with an intervention.
So now we're going to discuss valvular heart disease. So valvular heart disease is defined as it's caused from stenosis, regurgitation, or a combination of the two acquired from infections, underlying heart disease, or a degenerative process. So essentially it's stenosis or regurgitation at the various heart valves that we have, which I'll discuss individually in a moment. So the etiology of these is discussed a bit later. So we'll specifically be tackling infective endocarditis and rheumatic heart disease later. But I'll also, in the next couple of slides, be touching on age-related degeneration, hypertension, and some congenital conditions that can cause valvular heart disease. So we're going to go by valve. So we're going to start with probably one of the most common ones, which is your mitral valve. So as with each of these valves, there's either stenosis or regurgitation, and so I'll talk about each of these as we go along. So for mitral valve stenosis, this is a mid-systolic murmur, so you're going to hear it mid-diastolic murmur, apologies, and you're going to hear this through diastole. The common causes of this are rheumatic heart disease and congenital heart disease, so congenital narrowing of the mitral valve. And the clinical presentation, this is going to be a common theme throughout all of these, is that you're pretty much all of them can cause some sort of heart failure if it occurs chronically. And of course, most of them do also cause shortness of breath on exertion, which is SOBOE. Probably the more common mitral valve abnormality is regurgitation. So regurgitation meaning that the valve isn't able to close properly, so that blood is going to flow back during systole. So this is, of course, because blood is flowing back through systole, a pansystolic murmur, meaning it's going to be heard throughout systole. And the common causes of this is just a degenerative mitral valve. And it's interesting that about 3% of the population actually do have this. So this is normal age degeneration of the mitral valve. It also can be caused by rheumatic fever and infective endocarditis, with both of them being the mitral valve is one of the most commonly hit with both of those diseases. In terms of a clinical presentation, as I mentioned, you can have shortness of breath on exertion, so SOBOE. You can have fatigue, a dry cough, and of course, you can present with symptoms of and signs of heart failure. Now looking at the aortic valve, again, probably the aortic and the mitral are the two most common valves affected with stenosis and regurgitation. So aortic stenosis is, again, probably one of the more common ones. And it causes a mid-systolic murmur, which is essentially where you'll hear it during mid-systole. And the most common cause of this is actually aging. So it's calcification of the normal valve. Interestingly, you do have an increased risk with a bicuspid valve. So this is sort of a congenital abnormality where instead of having the 3 cusps of the valve, you only have 2. It can also be caused by rheumatic fever and any congenital abnormalities. So clinically, patients present with, as I mentioned, heart failure, with shortness of breath, a decreased pulse pressure, meaning that the difference between systolic and diastolic blood pressure is decreased, they present with angina, they can present with arrhythmias, and essentially all of these things come from a concentric hypertrophy, which is where you get a decreased amount of space inside the ventricle because it undergoes hypertrophy in a concentric manner, so it's going to circle around and around and sort of decrease the amount of volume of blood that can fit inside the heart. Next, you've got your regurgitation, so your aortic regurgitations. This is, again, an insufficiency of the heart valves where it's just going to allow blood to flow back during diastole. So this is an early diastolic murmur, and its most common causes are, again, aging. There's congenital causes such as Marfan's, and you've got your infective endocarditis, your rheumatic fever, which can also cause it as well as syphilis. So the clinical presentation, as I mentioned, is a heart failure, shortness of breath, and this time an increased pulse pressure. So you have an increased difference between your systolic and diastolic blood pressures. And this all comes from an eccentric hypertrophy, where essentially the cardiac ventricle dilates, so you can actually you almost get fluid overload of the heart. So that's really an important one to differentiate, is aortic stenosis will cause a concentric hypertrophy, which means that it's essentially working, it's the muscle hypertrophies in response to an increased pressure that the valve has to generate. Whereas regurgitation, it goes under eccentric hypertrophy because essentially it's a fluid overload, not that has to work harder against the increased pressure. It's just that so much blood is flowing back into the ventricle that it actually hypertrophies eccentrically. So now I'm going to get to the next two, which are a lot less common, so you don't really have to worry about them too much in terms of your exams. But obviously, in clinical practice, you will probably hear one of these going through your placements. So in terms of the tricuspid valve, you've got tricuspid stenosis. This is a mid-diastolic murmur, and its most common causes are rheumatic fever and congenitally. Patients most likely present with a reduced cardiac output, so shortness of breath and heart failure, if it's chronically there. So then in terms of regurg, you're going to tricuspid regurg, you're going to have a pansystolic murmur. Again, common causes are infective endocarditis, you've got trauma, and you've got any congenital abnormalities. And clinically, they can present with some sort of heart failure. Finally, the least common valve affected is your pulmonary, and that's going to involve, again, stenosis and regurg. So stenosis is going to be a mid-systolic murmur. The most common causes is rheumatic fever and congenital, but as I mentioned, rheumatic fever does rarely affect the pulmonary valve. Clinical presentation is essentially heart failure on the right side, and also right ventricular hypertrophy. In terms of pulmonary regurg, this is a diastolic murmur, with common causes being infective endocarditis, iatrogenic, so stuff that we've done, so drugs, etc., and rheumatic fever. And patients can present with heart failure, shortness of breath, and any arrhythmias. In terms of management of valvular heart disease, it really does depend on if the patient is symptomatic or not. So if the patient is symptomatic, the treatment should align with heart failure. So beta blockers, diuretics, calcium channel blockers, ACE inhibitors, those really form the key management plans for valvular heart disease, because if you're symptomatic, you're probably going to have some sort of heart failure. In terms of if it's caused by endocarditis, so if you already have a valve abnormality or valve disease, you increase the likelihood of having endocarditis. So anything with dental work, any orthopedic procedures, they'll provide antibiotics to prevent endocarditis from forming. Also, prevention of thromboembolism is really important. So aspirin, and also if we have a mitral valve affected, causing any arrhythmias, we want to give anti-arrhythmic drugs. So surgery really depends on the patient profile. So this is something that will be sort of assessed on a case-by-case basis. So we've got valve reconstruction, which is called annuloplasty, and we've also got a prosthetic valve replacement. So the ones to remember for this is that a mechanical valve is used in older people and a tissue valve is used in younger people. And the reason why is because a mechanical valve requires warfarin to be administered with it. And warfarin obviously is quite a potent drug in itself, and it can cause many, many side effects. So for a younger patient, they're going to have to be on this for life if they got a mechanical valve. So that's why we don't give younger patients mechanical valves. We opt for a tissue option when we can, and replace it in about every 10 or so years.
Here is the ETG guidelines for when you need antibiotic prophylaxis for infective endocarditis, which these days it's more or less never. So I think there was a PBL case where there's in first year there's some debate about whether or not someone should have had antibiotics when they went to the dentist because they had some previous history of bicuspid aortic valve. So the point to take away from this is that the only people that should have prophylaxis are people that are undergoing certain procedures that are listed on the next page, and those people have to have either a prosthetic valve, or prosthetic material used for valve repair, so not a complete valve, but just replacement of the rings around it and such. They've previously had infective endocarditis. They have congenital heart disease, but it specifically has to be an unrepaired cyanotic defect or a repaired defect that's not fully functioning, or it's still a little bit of a defect. Or if you're a high-risk patient that has rheumatic heart disease. So in that PBL case, the person didn't actually have rheumatic heart disease. They had congenital bicuspid aortic valve, which then led to aortic regurgitation and aortic stenosis at a young age. They didn't have rheumatic heart disease, but their brother or someone like that did. And that was sort of a discussion around indigenous health and rheumatic fever and rheumatic heart disease, which has nothing to do with acute infective endocarditis. We'll talk about that later. The only relevant point here is that if your valves have been damaged by rheumatic heart disease, that puts you at risk for later getting infective endocarditis. Now, the point about congenital heart defects is that it's only unrepaired cyanotic defects. So if someone has a VSD, yes, that increases their risk of infective endocarditis, but if it's flowing from left to right, so it's acyanotic, that's, the guidelines say you don't need prophylaxis. But if they develop Eisenmenger's syndrome, which is when a congenital shunt shifts direction to become a cyanotic shunt, where deoxygenated blood travels from the right heart to the left heart, those people can benefit from prophylaxis. And the only real procedures are like highly invasive dental procedures, so not a filling, but remove extraction of teeth or anything that's going to be cutting the gums. And then basically other things, really, getting your tonsils out, adenoids out. It's not. Basically, the point is that we're wasting antibiotics by giving them to too many people. And my dentist, when he does anything, will give me antibiotics. And I've got nothing, but he's just like, we were a bit rough on your gums today, so I'm going to give you some antibiotics. It's bad. There's no excuse for that. So let's talk about infective endocarditis. The pathophysiology, in a super simple sense, is bacteria that have colonized the valves or the endocardial tissue within one of the chambers. Most commonly, they colonize on the mitral valve and then the aortic valve. The right-sided circulation is less common unless you're an IV drug user. Then the tricuspid valve is most commonly affected. And the reason for that is when you inject IV drugs, you're injecting bacteria into your veins, which will travel to the vena cava and deposit that bacteria within the right heart. The first point of contact will be the tricuspid valve. Common organisms include staph, strep, enterococci, which are gut bacteria, and a few other organisms. So when you think about antibiotics, the prophylaxis for infective endocarditis sorry, not prophylaxis, but the empirical treatment, so you suspect it, but you haven't confirmed it or figured out which bug it is benzylpenicillin, flucloxacillin, and gentamicin. So you may not understand antibiotics yet, and that's fair enough. Your medical degree has basically done nothing to teach it to you in much detail. But doctors, for some reason, will expect that you know this stuff. So just super briefly, flucloxacillin was developed with the entire goal of making a good antibiotic to treat cellulitis. So cellulitis of the skin is commonly caused by staph. So flucloxacillin is what we give when someone has cellulitis because it can kill staph. Staphylococcus aureus can cause infective endocarditis, so that's why fluclox is a part of the empirical therapy. Streptococci are very easily destroyed by the other penicillins. So benzylpenicillin is just an IV version of your standard penicillin. And then enterococci, gram-negative bacteria, can be quite easily killed by gentamicin. So the combination of the three will give you good coverage for the most common organisms that cause infective endocarditis. If you want to learn more about antibiotics, I recommend that you either go on Boards and Beyond and watch those Step 1 antibiotic videos, or just try and find some YouTube videos that talk a bit about antibiotic coverage and, what drugs are good for gram-positives, what are good for gram-negatives, and so on. There's this thing called the antibiotic ladder, which helps you sort of tie everything together. The best thing that I learned was basically the history of, penicillin was good at killing gram-positives, but basically useless against gram-negatives. And then they developed aminopenicillin, which is ampicillin and amoxicillin. That increased the gram-negative coverage, but it made the drug really easily broken down by beta-lactamase, which means that it no longer worked against staph. So ampicillin doesn't cover for staph, but it does still cover for strep, and it will cover lots of other gram-negatives and gram-positives. The combination of amoxicillin with clavulanic acid makes it so that the staph that produced beta-lactamase can now be damaged by amoxicillin because the clavulanic acid acts as a beta-lactamase inhibitor. So as you go from penicillin to aminopenicillin, you gain gram-negative coverage, but you lose some gram-positive coverage unless you combine it with clavulanic acid. And then you've got flucloxacillin, which is a form of penicillin designed specifically to treat cellulitis with staph. Then you have the cephalosporins, and each generation of cephalosporin kind of did a similar thing, that initially they were great at covering gram-positives, and then as you go through the generations, they can kill more and more gram-negatives as well as gram-positives. So the sort of third and fourth generation cephalosporins are very, very broad spectrum. So empirically in the hospital, when people have like a pneumonia, a lot of the time they'll just be given a high dose of ceftriaxone, and that covers many, many, many different organisms. It doesn't cover anaerobic organisms all that well, and so the addition of metronidazole or clindamycin is useful. In anaerobic infections of the chest, so above the diaphragm, clindamycin is really good at killing those organisms. And then below the diaphragm, gut anaerobes and pelvic anaerobes are sensitive to metronidazole. So if someone has aspiration pneumonia where they've sort of vomited up some gut stuff and then breathed it in, that person will often be treated with ceftriaxone with metronidazole because the metronidazole covers the gut bacteria that are anaerobic. Clindamycin wouldn't work there because it's not a respiratory anaerobe, it's a gut anaerobe. That might have gone completely over your head, but at least you've heard these words, and in 2 years' time, maybe you'll be a little bit more prepared for the hospital than I was, because I had no clue about any of this stuff, and every time the doctors talked about it, they said, oh, this is basic antibiotics. You should have learned this in medical school. And I'm there like, haha, PBL, lol. So risk factors for infective endocarditis is previous endocarditis, damaged valves, prosthetic valves, congenital heart defects, which are worth knowing, immunosuppression, and if you have bacteremia anyway, the bacteria in the blood might just find their way into the heart and decide to live there. Here are some peripheral features and also a central feature of endocarditis. So in the top left is a Osler's node. That looks pretty painful. So Osler's nodes hurt. And the way to remember that is that the O of Osler can also stand for the word ouch. So Osler's nodes are ouch, they hurt. The bottom left is splinter hemorrhages. The bottom right is a Janeway lesion, which is painless and raised, or flat, sorry. And then here, looking at the eye fundoscopy, there's Roth spots, these fluffy red bits. So these are all features that are suggestive of endocarditis on physical examination. Something else just to be aware of, which you won't need it for your exam, but it's just good to have heard these things. Duke criteria is an algorithm that you can use to diagnose infective endocarditis. So the first two pathological criteria, if you've cultured the bug and you know that it's in the heart, then you've made the diagnosis. The next one is blood culture being positive, plus evidence of endocardial involvement on echocardiogram or the presence of a new heart murmur. Only one of those, you need both of those to be positive, whereas you only need one of the pathological criteria. Minor clinical features, you need all of these things, so a predisposing heart condition, fever, vascular, immunological, and microbiological evidence. So if none of the pathological or major criteria are present, but all of these minor criteria are present, then you can say that it's a definite diagnosis. Rheumatic heart disease. This is something that I think is kind of poorly understood, and a lot of people think that rheumatic heart disease and rheumatic fever are like to do with an infection. So rheumatic heart disease, firstly you need to know the Jones criteria for diagnosis, which we'll talk about on the next slide. But you need to recognize that this is a throat infection with group A strep. And then a few weeks later, after clearing up that infection, in some people that are predisposed, they will begin to mount an autoimmune reaction to an antigen present on the group A strep, which resembles antigens in the heart, joints, and brain. That acute inflammatory response is what is rheumatic fever. So by the time you've got rheumatic fever, you no longer have a bacterial infection going on. It's an autoimmune process. Okay, that's rheumatic fever. And then the brain and the joints heal, but the heart does not. The damage left over on the heart, especially the heart valves, mitral and aortic, that's called rheumatic heart disease. So it's an autoimmune process occurring later in life in someone who had group A strep infection and other factors. But it's not actually an acute infection. So the reason I put this here is to make sure you understand that infective endocarditis is an infection of the heart valves, whereas rheumatic heart disease is an autoimmune destruction of the heart valves secondary to a bacterial infection of the throat. Okay? The Jones criteria. J for joints, they've got pain in the joints. O for carditis, because O looks kind of like a heart. N for nodules, E for this rash, erythema marginatum, and S for Sydenham chorea. It kind of looks like epilepsy, and it's to do with this inflammation of the basal ganglia during rheumatic fever. Here are the nodules, so they're commonly on the extensor surfaces of the elbow and the knee. And here is erythema marginatum. It's an interesting looking rash. I've never seen rheumatic fever, but my friend is a nurse in the Northern Territory, and she sees a couple of people with rheumatic heart disease every day.
Heart failure. Let's talk about a brief idea of the pathophysiology, define cor pulmonale, the signs and symptoms, prevention and management. Pathophysiology and etiology. It's a complex syndrome that results from the heart not working. Okay, that can either be secondary to ischemic heart disease and myocardial infarction, or other conditions like diabetes, viruses, congenital disease, COPD leading to cor pulmonale, and many other things that can interfere with the heart doing its job. All heart failure means is that the heart is failing to produce enough cardiac output to meet the demands of the body. The general pathophysiology, if we have a look at the bottom of the diagram first, you'll see decreased cardiac output, which leads to activation of the adrenergic nervous system and the renin-angiotensin system. This leads to fluid overload, which increases the workload of the heart, leading to remodeling of the heart and less efficient functioning of the heart, which leads to decreased cardiac output, which again further activates these systems, which again overloads the heart and gives you a positive feedback cycle that makes your heart grow bigger and floppier and less efficient and fail more and more over time. Cor pulmonale is specifically a right ventricular failure secondary to COPD. Firstly, you get lung remodeling and all the inflammatory processes going on with COPD. That increases the resistance of the vessels in the lungs, which leads to pulmonary artery hypertension, which means the afterload of the right ventricle is quite high because it's got to pump blood into that high pressure pulmonary artery. That puts stress on the right ventricle, which then undergoes pathological remodeling. That ventricle fails, and you end up with right-sided heart failure, which presents as peripheral edema, ascites, hepatomegaly. Why does it do that? Because the job of the right ventricle is to take blood from the vena cava and pump it out to the lungs. If it can't pump that blood out, that blood pools upstream of the right ventricle, which would be the liver from the hepatic vein, and everything else downstream of the vena cava being your legs and your abdomen, leading to peripheral edema and ascites. Left-sided heart failure means that you're unable to get blood from the pulmonary vein out to the body. So blood pools in the pulmonary circulation, leading to pulmonary edema, orthopnea, cough, and shortness of breath. Right-sided heart failure, as we said before, means you're unable to get blood from the systemic circulation, so the vena cava, out to the lungs. So blood pools in the body, being peripheral edema, hepatomegaly, etc. Most people have elements of both by the time you see them in real life. A little mention of chest x-rays in heart failure. You can remember the features of heart failure on a chest x-ray through A, B, C, D, E. Alveolar edema, curly lines, cardiomegaly, dilated upper lobe vessels, and pleural effusion. These are all signs of left-sided heart failure. The blue arrows reflect curly B lines, and these are fluid collecting between the segments of the lung, which tells you that there's pulmonary edema occurring. This is cardiomegaly, where the heart has more than 50% of the transverse diameter of the chest. So the cardiothoracic diameter is greater than 50%. Note that this is a PA X-ray, the correct type for diagnosing cardiomegaly. An AP X-ray magnifies the heart, and you can't make an accurate estimation of the size of the heart. There you can see everything nicely depicted on one diagram. So blood vessels can be seen at the top of the lungs, which normally you shouldn't see them there because gravity pulls everything down. But when the lung becomes congested, there's just so much fluid that you can start to see blood vessels at the top of the lung. Curly B lines, cardiothoracic ratio. This is the New York Heart Association classification of heart failure. It's class 1 to 4. 1, no limitation. 4, limitation with basically all activity. Prevention. This is the job of a general practitioner, the most important job in the world. Exercise, smoking, fruit and vegetable, alcohol, substances that are stimulating to the heart but also damaging like amphetamines and cocaine. You need to control all of that. You need to control blood pressure, control diabetes, prevent heart attacks, which you can do by giving statins, and protect someone's heart after a heart attack through ACE inhibitors and beta blockers to prevent them getting heart failure. Everything on this page is what a general practitioner does. So a cardiologist doesn't really get to do any of this. This is what a GP does. Managing heart failure is what a cardiologist does, but also a GP in a lot of places, and the article on that is very good. The general principle, and I want to firstly just say that you don't need to know that much about this, but there's HFrEF and HFpEF. HFrEF is HFrEF, heart failure with reduced ejection fraction from the left ventricle. That's also known as systolic heart failure. That's basically what you think of as heart failure. The heart fills with blood and then it doesn't manage to pump it all out. That's the one that we treat with all the drugs that you've learnt about. HFpEF is a different condition that can happen when the heart becomes fibrosed and constricted, like in diabetic cardiomyopathy, where the actual ventricle doesn't fill very well. So even though the heart's not working that well, the ejection fraction looks normal because the ejection fraction is the stroke volume divided by the end diastolic volume. If the end diastolic volume goes down because the heart's stiff and it can't actually fill, then even if the stroke volume goes down, the ratio of the two will look normal. Okay? So in HFrEF, let's say the heart filled with 100 units of blood. The ejection fraction being less than 40%, which is the definition of HFrEF, would be only 30 units of that got ejected into the aorta. And so you'd say they have a 30% ejection fraction, which is less than 40, and they have heart failure. But if they have preserved ejection fraction, the heart might have only filled with 40 units and then pumped 30 of those. So the ratio of the two looks awesome, but the actual total amount of blood is heart failure. It's just not by the ejection fraction definition. You should have a read of the article on the therapeutic guidelines, but basically drugs that help are ACE inhibitors, diuretics, angiotensin receptor blockers, and beta blockers. Hypertension. Primary, secondary, prevention, management, complications. Essential hypertension is basically hypertension where we don't understand the cause, but it's definitely not a secondary cause. In Australia, the decision to start antihypertensive treatment should be based on absolute cardiovascular risk. If someone's young and low risk, you might avoid starting them on a medication because the side effects might not be tolerable. But if they're older, have high cholesterol, and their absolute risk is unacceptable, then you should start them on a drug. And it's standard practice that if their blood pressure is quite high regularly, for example, over 160 over 100, you would just start them on a drug regardless of absolute risk. Typically, the target will be to be less than 140 over 90. There is like a 100-page document here, but a couple of the pages are worth looking at. They classify the severity of hypertension and give a detailed discussion of management. This is a brilliant document from the Heart Foundation. Non-pharmacological measures include exercise, healthy eating, reducing alcohol, looking after sodium, and losing weight. I know plenty of people that had high blood pressure. They changed their diet to sort of a more plant-based diet. They started regularly jogging, meditating, and they now have a normal blood pressure after losing a bit of weight. Most people, in our Western world anyway, will end up requiring 2 or more drugs to get their target blood pressure. Now, you should understand that if someone can implement lifestyle measures, you can start to remove these drugs. But for many people, they will require multiple drugs, and you should pick 2 drugs that complement each other. So a diuretic plus an ACE inhibitor, or an ACE inhibitor plus a calcium channel blocker. And it's best to have 2 different classes of drugs that are at a low dose than giving a really high dose of one class of drug. This is just a side note that I can remember from undergrad pharmacology, and I always thought it was interesting. You shouldn't combine a beta blocker with a calcium channel blocker that acts on the conduction system of the heart. Not all calcium channel blockers do that, but verapamil and diltiazem do. The other calcium channel blockers like nifedipine don't have this issue, but when you combine the 2, they both act on the conduction system of the heart, and you can actually cause heart block and essentially heart failure. Secondary hypertension. If you've got a child with high blood pressure, you can almost guarantee that it's some kind of secondary cause. Secondary causes include renal artery stenosis, kidney disease, adrenal tumors, and other endocrine disorders. If someone has high blood pressure and really low potassium, you should suspect that maybe they have a tumor secreting aldosterone as their cause of high blood pressure. And if things really aren't making sense, you can get a CT scan to detect renal artery stenosis. Renal artery stenosis is when the renal artery is blocked and so blood flow is reduced to the kidney. As we said at the start of this lecture, the kidney releases renin in response to what it thinks your blood pressure is, and the way that it can tell what your blood pressure is, in one way, is how much blood goes into the kidney. If less blood goes into the kidney, the RAS system will be more activated. So renal artery stenosis leads to RAS activation and hypertension. It's even worse if there's bilateral renal artery stenosis. Glomerular filtration is maintained by making sure that you've got a lot of blood going into the glomerulus and a high resistance of blood going out of it, so that, like squeezing the end of a tube of toothpaste, you can make sure that there's enough pressure inside that glomerulus to get the fluid out, to filter it. And I'll show you that on a diagram below. So blood goes into the glomerulus through the afferent arteriole, and that's dilated by prostaglandins. And then it exits through the efferent arteriole, which is constricted by angiotensin II. The best case for having a high glomerular filtration rate is if the afferent is really dilated so that blood can get in, and then the efferent is really constricted so that it's hard for blood to get out, which will increase the pressure inside the glomerulus, helping to push fluid across the glomerulus, increasing glomerular filtration rate. In renal artery stenosis, glomerular filtration is maintained because the efferent arteriole is kept in a constricted state by angiotensin II. If you give an ACE inhibitor, you remove the effects of angiotensin II, and you will drop someone's glomerular filtration rate. That's okay if they've only got renal artery stenosis on one side, but if it's both kidneys, you'll drop the GFR in both kidneys and give someone a very serious case of acute kidney injury. Triple whammy is a related concept when you combine an NSAID, an ACE inhibitor, and a diuretic. As we said, GFR is best when the afferent arteriole is dilated, the efferent arteriole is constricted, and when there's enough blood volume around to give it to the kidney. If you give someone an NSAID, which inhibits the production of prostaglandins, you'll end up with a constricted afferent arteriole. If you give them an ACE inhibitor, you'll end up with a dilated efferent arteriole. And if they don't have enough blood volume to perfuse their kidney, then the whole thing falls apart, and that's what happens when you give them a diuretic as well. Now, given that you can buy ibuprofen in Woolworths, and that everyone's on an ACE inhibitor, and that they might also be using a diuretic, this is a terrifying reality that it's very easy for people in the community to give themselves a kidney injury. Complications of high blood pressure. Chronic kidney disease is a really important one with a high mortality and morbidity rate, especially for rural and remote areas and Aboriginal and Torres Strait Islander groups. Heart attack, heart failure, stroke, aneurysm disease, and retinal disease.
Note the difference between an aneurysm and a dissection, that an aneurysm is basically just when the whole vessel is becoming quite dilated and stretched, whereas an aneurysm is when the actual vessel lumen has been torn and you're bleeding into the wall of the vessel, creating a false lumen. So there's a true lumen and a false lumen. These are both causes of large arteries, but in one of them it's one big tube that's stretched, and in the other it's a smaller tube with a bleed around it into a bigger, false lumen, creating a large artery. Generally speaking, aneurysmal disease is associated with smoking as a risk factor, as well as age, and dissection is associated with high blood pressure. Aneurysmal disease is also, closely tied in with connective tissue disease, interfering with the structure of the blood vessel. But also connective tissue disease can lead to aortic dissection in Marfan's disease, for example.
Now, of course, Griffith's curriculum on the cardiovascular system would not be complete without some lovely embryology. And so that's what I'm going to be going through with you guys today. Disclaimer, most of this is above and beyond what you need to know. I will highlight what is important for your exams because it's very easy to get lost in this, as always with embryology. And there are a few things that are pretty important for exams, as I mentioned, but also for clinical practice. And the first kind of important thing is actually the fetal versus adult circulation. And so we're going to talk about a little bit about this. We're going to start with the fetal circulation. So on the diagram on the right, I've sort of got an example of what the fetal circulation looks like. And so you can kind of follow along with me as I go through and explain where does the blood go. So we're going to start with the arrow on the left-hand side of the diagram at the umbilical vein. It's pretty much 80% saturated oxygen returns from the placenta via the umbilical vein, and it heads straight for the liver. Now, most of this blood actually bypasses the liver and goes straight into the inferior vena cava via the ductus venosus. And the ductus venosus essentially, it's like a bypass tunnel for the blood to just sort of skip the liver, because obviously, if you got stuck in the liver, most of it, the blood's going to be lost there. Of course, some blood is given to the liver because it does need to survive, but most of it goes straight to the inferior vena cava. From here, essentially the blood mixes with the oxygenated blood that's coming from the portal vein and the inferior vena cava from the lower limbs. So it mixes a little bit here. And then it enters the right atrium. Now, most of the blood goes straight through the right atrium into the foramen ovale. And you don't really need to know why it does this, but for people who are keen and interested to know, there is something called the Eustachian valve, which is a valve on top of the inferior vena cava, which kind of shunts the blood up into that direction. So from here, this is where it kind of differs. So most of the blood goes from the right atrium straight through the foramen ovale into the left atrium. And obviously from the left atrium, it enters the left ventricle and then to the aorta. But as I mentioned, some of it stays in the right atrium and mixes with the deoxygenated blood coming from the superior vena cava. And it goes from here into the right ventricle, into the pulmonary artery, and the pulmonary trunk. And then most of it actually then goes through another duct called the ductus arteriosus. Now, the reason why because of this is because there's such a high pulmonary pressure that the blood will mostly go from a place of high pressure to low pressure. And the aorta is much lower pressure compared to the pulmonary system. So most of the blood goes straight through the ductus arteriosus into the aorta. And then from there, once it enters the aorta, it then travels all the way through your circulatory system in your body, giving oxygenated blood to everywhere. And then at the iliac arteries, you have two umbilical arteries which come off and return the slightly deoxygenated blood to the placenta to start the cycle again. Now, essentially, the key thing here is the changes at birth to yield the adult circulatory system. So on the diagram on the right now, I've got the adult circulatory system, and there are some key things that occur which cause these changes. Now, the most important thing about this to know is probably A and B, knowing the process of them, but the rest just knowing the names of what they turn into, because they are common anatomical landmarks and they can be examined on your anatomy exam. So, starting with the ductus arteriosus, this becomes the ligamentum arteriosum. And the main reason for this is due to the constriction due to a rise in blood oxygen levels, and also a removal of prostaglandins. Now, what's interesting here is there's for treatment of neonatal patent ductus arteriosus, you actually give NSAIDs, which help close the ductus arteriosus. Now, usually it closes about 1 to 3 months after birth, so it does take some time to close, but to fully close, but most of the closing does occur straight after birth. Next, you've got your foramen ovale. This becomes your fossa ovalis in the adult, and the main reason for this is twofold. You have an increased blood flow to the lung because you're breathing. This sort of closes the ductus arteriosus and causes an increased pressure in the left atrium. But then you have a loss of placental blood flow in the right atrium because obviously the placenta is not providing blood anymore. And this actually has a massive reduction in the blood volume that's in the right atrium. And therefore you have a decreased pressure in the right atrium. So you have an increased left atrial pressure, decreased right atrial pressure. This is going to snap shut the foramen ovale to become the fossa ovalis. And I've got here that it snapshot the septum previa and on septum secundum. And this is just the fancy terms for what makes up foramen ovale. Next, you've got your umbilical arteries. These become your medial umbilical ligaments. Again, these can come up in your anatomy exam, so it's good to know where they come from. This mainly goes from changes in oxygen levels. And then you've got your umbilical vein, that becomes your ligamentum teres, and your ductus venosus, that becomes your ligamentum venosum. And these are two really key anatomical landmarks on the liver, and again, could be assessed on your anatomy exam. So now we've sort of talked about the normal. Let's talk about the abnormal, so congenital heart diseases. There's only two main classes that you need to know. And in fact, all of them can be classified into these two classes. So you have your cyanotic heart diseases, and these cause a right to left shunt, meaning that the blood is going from the right atrium to the left atrium, or the right ventricle to the left ventricle, indicating that it's bypassing the lungs entirely, meaning you're going to most likely result in cyanosis, and that's why it is cyanotic. Acyanotic is a left to right shunt, meaning that it's going from the left atrium or left ventricle to the right atrium or right ventricle. And this indicates that oxygenated blood from the left side of the heart is now entering the right side of the heart. So it's not necessarily going to cause cyanosis. In fact, it probably won't at all. But what it will do is cause a greater strain on the heart and a reduced ability to get enough blood out of the heart. And there's a couple of mnemonics to remember. Cyanotic heart disease, one that's really common is the 5 T's. So as you go up in the numbering system, you have an increase in the things that are going wrong. So as you can see on the diagram. And then you obviously have listed out this acyanotic heart disease. It's not really a cool mnemonic for it, so it's just worth to know that these things exist. And I'll point out which ones are the most important as I highlighted them. So the first two really important ones for the acyanotic category are the coarctation of the aorta and the atrial septal defect. So coarctation of the aorta is essentially narrowing of the aorta, so the aorta, mostly the aortic arch, somewhere along it. And the main reason for this is actually tethering or pulling off the ductus arteriosus. And because of this, you have two main types. You've got your preductal and your postductal. There are, of course, some other ones, but these are the two main ones to know. And the reason why it's important to know these two is because whether there's compensation with a ductus arteriosus or not. So compensation with ductus arteriosus essentially means that in the beginning, the fetus is going to survive with not many abnormalities because the ductus arteriosus is actually compensating for most of the lost blood. So then a postductal, this is where you have no compensation with the ductus arteriosus, and you start to get some of these symptoms and signs arising. So failure to thrive, fatigue, shortness of breath, dizziness, upper limb hypertension, and radiofemoral delay. The last two are really important clinical signs and something very much worth to commit to memory on if you see someone with these signs. The differential diagnosis should be coarctation of the aorta, purely because if you can imagine a postductal coarctation, which is on the far right diagram, this is going to cause the blood flow to get to the radial artery first. So the radial artery is found in your wrist before the femoral artery, which is found in your legs. And you can see why, because the blood is going straight into your brachiocephalic trunk and your subclavian artery, but then it's got a little kink before it can actually enter to the descending aorta, and therefore you're going to get this radiofemoral delay. And same with upper limb hypertension, because the coarctation of the aorta is causing an excessive peripheral increase in peripheral resistance, meaning the heart has to pump a lot harder to get to overcome this. And because of that, you're going to get a massive amount of pressure built into the left ventricle and cause upper limb hypertension. You then have your atrial septal defects. There's two main types. There's your ostium secundum and ostium premium. Really important to know is that patent foramen ovale, PFO, is not an atrial septal defect. That's a really important distinction to make. Atrial septal defects are ostium secundum damage and ostium premium damage. And I've got a little diagram below which shows what those two things are. And essentially, it's just damage to one of those two things which causes these atrial septal defects. And so you get a systolic murmur with an atrial septal defect. You get fixed splitting of S2, meaning that the aortic and pulmonary valves shut at different times. That's essentially what splitting of S2 means. You get shortness of breath and you get dizziness. And you can also get something called Eisenmengers, which is a right to left shunt. And this is essentially when an atrial septal defect turns really bad. And essentially what occurs is that the right atrium gets so much, over time, gets so much much more muscular because of the amount of blood that it's getting from the left atrium, that actually increases its pressure so much that it overcomes the left side. And so you get a swap from a left to right shunt to right to left shunt. And this becomes cyanotic. So then, two really more important ones to know is the ventricular septal defect. This is failure of the muscular or membranous septum to develop. The membranous is a more common ventricular septal defect. So mostly these are actually asymptomatic, which is good, but you can get left or right ventricular hypertrophy, and its associated sort of heart failure symptoms. You can also get something called a paradoxical embolism. This is when an embolism that's coming back from circulation, so coming back to the right side of the heart, it sort of goes into the left side and up into the brain, and that's what a paradoxical embolism is. You also get a pansystolic murmur with a VSD or ventricular septal defect. Next, the one I was talking about, the patent foramen ovale. This is not a true atrial septal defect, and it's actually just failure of the ductus ovalis to close. And this causes a left to right shunt, but may cause episodic cyanosis, mostly when the baby is crying or something like that, and when you get an increase in the pulmonary vascular pressure, and this actually induces a left to right shunt periodically, not all the time, but when you get that increase in pulmonary hypertension, such as crying. Now we're going to talk about cyanotic heart diseases, and you can see I haven't highlighted these two. It's because they're not really assessed that much, but they're good to know. So you've got total anomalous pulmonary venous return. This is when the pulmonary veins connect to the right atrium instead of the left, and you get a parallel circulation. So obviously that's going to cause severe cyanosis. You've also got something called tricuspid atresia. You might hear something called the Epstein anomaly. This is something that's similar, but Epstein anomaly is where you have a decrease in the amount of valves that the tricuspid valve has. But a tricuspid atresia is just no tricuspid valve at all. And obviously this is going to cause a great amount of cyanosis. And in fact, you need another congenital heart disease defect to live in these, as well as with the total anomalous pulmonary venous return. Again, so I haven't highlighted truncus arteriosus, not really important to know, but essentially all pulmonary, systemic, and coronary circulation originates from one trunk. You get a very loud systolic member with this one. So transposition of the great vessels, or TGV. The reason why this is important is it could come up in an anatomy exam with the following X-ray, which I have shown here. This is where obviously you're going to get transposition of the great vessels. It's where the pulmonary trunk and the ascending aorta, they swap. And you essentially get parallel circulation, so you're dependent on another defect to survive. It can cause central cyanosis and something called an egg on a string sign. And I know you're going to have to use your imagination on this one, but this is what it looks like. I would just look at this, try and commit it to memory for the anatomy exam because it could come up. But there's one more, which is much more likely to come up, which I'll talk about in a second. And it's right here. So tetralogy of Fallot. This is probably the one that's, if it's going to be assessed, it will be assessed because they really like this one for some reason. There's four main features. You get pulmonary stenosis, right ventricular hypertrophy, an overriding aorta, and a ventricular septal defect. So those are the four things, tetralogy, four. So there's four more things that are going wrong. It causes central cyanosis and ejection systolic murmur. And you get something called a boot-shaped heart, which I've shown here on the X-ray. This is one I would definitely commit to memory because I'm pretty sure we got this on our anatomy exam last year. So it could be a vibe to just commit that to memory. And that sort of concludes our trip on the embryology system.
Acute pericarditis, inflammation of the pericardial lining of the heart. The causes can be idiopathic, infectious, they can be secondary to MI, they can be from uremia, so when all the toxins of kidney failure accumulate in the blood, they can irritate the pericardium. It can be secondary to a nearby cancer in, for example, lymphoma in the mediastinal lymph nodes, or breast cancer, lung cancer, esophageal cancer. It can be an autoimmune process in someone with lupus, rheumatoid, or scleroderma. Or it can be secondary to blunt or sharp trauma, getting punched really hard in the chest, or getting stabbed in the pericardium. That's quite inflaming. The infectious agents, the most common cause in the West is viral infection by large. But over in other countries, you might see things like tuberculosis causing pericarditis. The other sort of, high yield for clinical years, low yield for your exams, is that following a myocardial infarction, if they get pericarditis weeks to months after it, that's called Dressler's syndrome, and it's an autoimmune process where the proteins that get sort of exposed from the necrosing myocardium mounts an immune response weeks later, which goes and attacks the pericardium. That's a unique autoimmune pericarditis. Clinically, there's pleuritic chest pain, which basically means the pain is worse when you take a deep breath. It's positional, so when they get up and sit forward, the pain gets better. They might have had a recent viral infection, and when you auscultate them, you will maybe hear this pericardial friction rub, which people say feels like rubbing your hair between your fingers, like this. I don't know if you can hear that, but that's what people say. Now, it's really good that you learn this because it's a cause of chest pain, and it's quite a common one. So when you're doing Socrates and you look at exacerbating and relieving factors, you can say that taking deep breaths in will make this hurt more, and moving forward, changing position, relieves the pain. Of course, something like esophageal reflux is also kind of positional. If you sit up in bed, the reflux will get a bit better because of, how the sphincter works relative to gravity. But it's just good to keep in mind that in someone with acute chest pain who's young, who's just had a virus, if that chest pain gets better on leaning forward and gets worse when they take a deep breath, there's a chance that could be pericarditis. ECG findings are really helpful here, and it's really cool. So PR depression is only seen in pericarditis, from what I've seen. And then ST elevation that's got a sort of concave appearance is spread across all of the leads, at least most of the leads, is a unique feature of pericarditis. So there's ST elevation that's got this concave shape in leads 1, 2, AVR, V2, V3, V4, V5, V6, AVF. So obviously this person isn't having a STEMI in their entire heart. They're having pericarditis. And if you look at leads 1, 2, a little bit of AVF, V3, and the other precordial leads, the PR segment is depressed relative to the isoelectric line. So this ECG is really characteristic of pericarditis. The treatment is anti-inflammatories plus colchicine. In America, they don't use colchicine right away, but in Australia, the guideline is to start both. So ibuprofen or aspirin plus colchicine. Colchicine is a drug that inhibits the sort of invasion of inflamed tissue by white blood cells. So it's a good anti-inflammatory agent. It's also used during acute flares of gout. That's where you will see it maybe this year, but probably in second year. Pericardial effusion can be related to acute pericarditis, but also other things. So you could have blood in the pericardium from wall rupture. So when you get an MI and that fibrosed portion of the ventricle, it can split, and then blood will be leaking from the ventricle into the pericardial space. Trauma or aortic dissection, because the pericardium comes up onto the root of the aorta. Cardiac surgery. And then if it's not blood, it's more of a serous transudate kind of fluid. That could be pericarditis, cancer, uremia, autoimmune, or even hypothyroidism, which is an interesting point for P4P in next year when you look at endocrine. Thyroid does so much in every single organ, so it doesn't surprise me that it does something to do with pericardial effusion. Cardiac tamponade, on the other hand, is a terrifying, life-threatening condition where the size of the effusion has gotten so great that cardiac output is significantly diminished. So first you get a fluid collection, and then that increases the pressure in the pericardial space, pushing down on the heart. So that compresses the heart. And because the right heart is softer than the left heart, the right heart gets more compressed. And then the right interventricular septum will bulge up into the left ventricle. And then now the size of the left ventricle is significantly reduced. So the end diastolic volume of the left ventricle will be reduced. The stroke volume will then be reduced, and so the cardiac output is reduced. You then get venous congestion, so it looks like you're in acute heart failure, as well as a massive drop in cardiac output, which can kill you when you stop perfusing the brain. As well as that, because there's this pressure pushing down on all the chambers, there'll be an equal end diastolic pressure across all 4 chambers on cardiac catheterization. So when you float a Swan's-Ganz catheter, that's like a little pressure sensor that you put into the pulmonary artery, typically, to check pulmonary capillary wedge pressure. As you're pushing that in, the characteristic pressures of the atria and the ventricles is basically that the ventricular pressure during diastole is 0. Okay? It's only the pulmonary artery that will have a pressure during diastole, and that's actually how they can tell that the catheter's in the right spot. They look at the pressure wave as they're pushing it in. because the whole heart is being compressed though, when the heart relaxes in diastole, it's being pushed down against this pericardial pressure. So the diastolic pressure doesn't reach zero in the ventricle as it normally would. It'll reach whatever the pressure is within the pericardial tamponade space. The clinical features they include Beck's triad, you should probably know that, which is a combination of hypotension because of reduced cardiac output, muffled heart sounds because the heart is floating in a big bag of fluid that make it hard to hear the heart sounds, and jugular venous distension, so the JVP will be elevated, and that's because the venous blood isn't able to go into the heart because the ventricle isn't filling very well. If you see these three things and someone looks sick, you should be really scared that it's cardiac tamponade. Another feature is pulsus paradoxus, which is a greater than 10 millimeter drop in systolic blood pressure on inspiration. So when people breathe in, the lungs get bigger, and so there's more blood inside the lungs, which means there's less blood returning to the left side of the heart. Okay? It's more complicated than that, but that's the easy way I remember it, is that as you breathe in, the lungs get big, so they're filled with blood. And then as you breathe out, the chest wall compresses down against the lungs and squeezes that blood back into the left atrium. So left-sided circulation, in terms of the left ventricle, is reduced on inspiration and then increased on expiration. And it's the opposite thing on the right side of the heart, where as you breathe in, the negative intrathoracic pressure increases venous return, and so blood flow increases on inspiration to the right atrium, and then as you breathe out, that will decrease the filling of the right heart because there's no longer that negative intrathoracic pressure to improve venous return. That's the reason why, murmurs on the left side of the heart will typically be louder on expiration, and on the right side, they'll be louder on inspiration because there's more flow respectively in each of those breathing patterns. So normally then, if breathing in reduces your left ventricular venous return, pulmonary blood return, that will drop the blood pressure as you breathe in, right? Because there's less blood going into the left ventricle, so your blood pressure will drop as you're breathing in. But it shouldn't drop more than 10. If it drops more than 10, that suggests that you're having a really hard time returning blood to the left ventricle, which suggests that there could be cardiac tamponade happening. There are obviously other causes of that, but this, just in terms of MCQs, pulsus paradoxus and cardiac tamponade go hand in hand. The reason it's called pulsus paradoxus is it's a paradoxical pulse. So the radial pulse can only be felt when you've got a systolic blood pressure greater than 90. And so if someone had a systolic pressure of, say, 100, and then as they breathe in, their blood pressure drops all the way down to 80, their radial pulse will disappear as they breathe in. And that's paradoxical because only dead people don't have a pulse, but you're alive. So you're a paradox because you don't have a pulse, but you're breathing. And features of obstructive shock, which is basically the low cardiac output with signs of venous congestion. We'll talk about shock more later. There's an ECG finding called electrical alternans, which is an alternating high voltage, low voltage QRS. And it's basically as the heart sloshes back and forwards within this pericardial fluid, whenever it moves closer to the chest leads, the QRS will be high voltage, and then as it swings back, it'll be low voltage. And that's the ECG I've shown above, where it goes high, low, high, low. That's the heart sloshing back and forwards within the fluid. This is not a good image, but basically look at the white stuff here, and you can see the septum here, the interventricular septum, so you can tell kind of roughly that we're looking sort of at the bottom of the heart here, with the right ventricle at the top and the left ventricle at the bottom. So this is the sternum, and you know that the right ventricle sits most anteriorly while the left heart sits posteriorly. You can sort of trace an outline of the heart, and then you see this black anechoic shadow all the way around the heart, and you can kind of see that the right ventricle doesn't look so good. This is a bedside echo showing cardiac tamponade. What you would then do is, given that you can see the sternum, you would insert a needle, like a spinal needle that you do use for lumbar puncture, just inferior to that, xiphoid process. And you will then see the needle appear on echo, and you'll drain that fluid. You don't want to put the needle in too far, because then you might stab the ventricle and even more blood will collect, and that would be fatal. But as long as you've got echo, you can at least guide that needle in so that it just goes in far enough to get the fluid without being forcefully stabbed into the ventricular wall. Constrictive pericarditis is an outcome when you've had long-standing acute pericarditis. It's very rare in the West because we have modern medicine and we pick things up, but people from other countries, they could have tuberculosis for ages and not know about it, and then one day their heart doesn't work properly. So when you've had inflammation for greater than 3 months, you get this thickened, rigid, and fibrosis of the pericardium. The features are that you'll be fluid overloaded, right? Because your heart can't expand that well during diastole because it's in a tight bag. There's a confined volume. So therefore you get venous congestion because all that venous blood can no longer fill the heart properly. So you'll have a distended JVP, Kussmaul's sign, hepatomegaly, and peripheral edema. Kussmaul's sign is basically when you breathe in, we said that negative intrathoracic pressure improves venous return to the right side of the heart. So normally on inspiration, the JVP, if it's visible, will decline, right? It'll fall because that venous blood, that column of JVP blood is being sucked down into the right atrium. That's what should happen. But if you've got constrictive pericarditis and you're no longer filling your right heart properly, then there'll be a failure of the JVP to fall during inspiration, and that's Kussmaul's sign. The other features will be reduced cardiac output and a pericardial knock, which is that as the ventricle fills, once it gets full enough, it'll smack really hard against that constricted pericardium, and you'll literally hear a knocking sound with every heartbeat. And they can also get pulsus paradoxus. So that was constrictive pericarditis. Constrictive pericarditis. This other disease that we'll sort of round off on is REStrictive cardiomyopathy. So constrictive pericarditis, constricting the heart from the outside, and then REStrictive cardiomyopathy, restricting the heart from the inside. So the heart becomes stiff in its muscle and is no longer able to fill as well in diastole. The pericardium's normal and flexible, but the actual heart wall itself is no longer flexible. So this is a cause of HFpEF, heart failure with preserved ejection fraction. It's when you get a stiffening of the heart wall because of fibrosis. And there are many conditions that can cause this, but some of them are amyloid, sarcoid, hemochromatosis, sclerosis, and radiation. Finally, I want to talk a bit about lipids. Basically, all I'll say is that there's lots of different phenotypes for dyslipidemia. Type 1 has high triglycerides, and the rest I've just never bothered to learn. The bad thing about it is if you've got low HDL, which is the good one, high LDL, that will, as well as having high levels of lipoprotein A, lead to atherosclerosis. Okay, that's kind of all you really need to know. The targets are that the total cholesterol shouldn't be more than 4, and the HDL should be at least 1. They're just good numbers to remember, for DHC especially. let's talk about diabetes. Primary diabetes, type 1 and type 2 are what we know. Type 1 is an immune pathogenesis involving autoimmune destruction of pancreatic islet cells with severe insulin deficiency, which prevents the use of glucose in skeletal tissues, and when it's untreated can result in diabetic ketoacidosis, where because the tissues are starving, they use fat metabolism, which produces acidic ketones, and at the same time you'll have hyperglycemia because the glucose is left in the blood. Whereas in type 2, it's a multifactorial condition involving, obesity, some genetic factors, multiple factors from the lifestyle, a high-calorie diet. You get insulin resistance, and then over the years, you'll eventually get insulin deficiency with chronic insulin resistance. The equivalent emergency is hyperosmolar hyperglycemic state. HHS, also known as hyperosmolar hyperglycemic non-ketotic state, which is HHNK or HONK, it has a mortality rate of about 40%. DKA only has a mortality rate of 4%. So it occurs in people that are old, dehydrated, comorbid, and have had poorly controlled type 2 diabetes for a long time potentially, and typically have another disease at the same time, like sepsis or a heart attack. You can see why the mortality is so high, even though they're quite similar conditions. The chronic complications of long-term diabetes can be broken up into macrovascular and microvascular. Macrovascular, the large vessels, include the cerebral vessels for stroke, the heart for the coronary vessels, myocardial infarction, and the peripheral circulation for peripheral arterial disease. Microvascular complications include the kidney, the retina, and the small vessels supplying the nerve sheath. Hyperglycemia is also directly toxic to nerves. The first sort of microvascular change is diabetic retinopathy. And if someone presents with diabetic nephropathy, which can be detected by albumin being present in the urine, microalbuminuria at first, people at that stage almost definitely have some degree of diabetic retinopathy. Maybe it's been missed. So the eye is first, then the kidney, and if they have peripheral neuropathy, you can guarantee that they have nephropathy and retinopathy. If they have neuropathy, there's a good chance they have peripheral arterial disease and atherosclerosis and are at a high risk of stroke and MI. All of these complications are worse in type 1 diabetes because it's more difficult to achieve glycemic control because, if you don't take insulin, your body has no insulin. Whereas at least in type 2 diabetes, even if you're on insulin, your body can at least produce a little bit of basal insulin to soften those hyperglycemic peaks. Diabetic neuropathy. There are a couple of different kinds. Here are some I've highlighted. So you've got the sensory neuropathy, which is the loss of proprioception and vibration sensation in the peripheral limbs, especially the hands and feet, paresthesias like pins and needles, or just not feeling your feet. There's another version of this, which is an acute pain neuropathy, where they get a painful neurasthenia. Then there's autonomic neuropathy, where the both parasympathetic and sympathetic nervous system fibers are damaged, and if it's damaged to the gut, you'll get gastroparesis, which is delayed gastric emptying, constipation, diarrhea, postural hypotension, sexual issues. If you get low blood sugar, you won't be able to notice it because it's the sympathetic nervous system that gives you your tachys when you get hypoglycemic, issues with sweating, and then an awful condition called diabetic amyotrophy, which is where you get degeneration of the lumbosacral plexus, typically unilaterally, and you get wasting of the hip and thigh muscles, especially the quadriceps, and it really hurts. It's the most painful diabetic complication. Diabetic foot is something to really understand well. It's a consequence of poor blood flow, poor nervous innervation, together meaning that, if you can't feel, it's very easy to cut your foot and not notice it and not clean it. And then having poor blood flow and hyperglycemia mean it's hard to heal that wound. And the hypoxia caused by poor blood flow will provide an anaerobic environment for some very nasty bacteria to grow, which don't normally grow on the skin. And these things can get so bad that you end up with ulcers that require the amputation of toes, feet, or legs. Another condition to know about is Charcot's foot. It's kind of way more complex than you'd expect. It involves inflammation from diabetes and an actual change in the metabolic activity of the bones in the feet. Basically, it's just a deformity of the foot that's associated with diabetes. You end up with rocker bottom feet, so they're curved on the bottom. For diabetic foot testing, we use that monofilament, which provides a specific amount of pressure for two reasons. One is it's standardized, and two, it means that you can't accidentally go poke a hole with a little pinprick in someone's poor little foot. The sites that you touch are, one on the back of the foot, and then on the bottom of the foot, where it's widest, you do 3, then 3, and then where it becomes more narrow, you do 2, and then 1 on the heel. It's very easy to remember. It's just wherever it's wide, you do more, and then it comes down in a triangle. In terms of interpreting that examination, I found this guideline, but it kind of confuses me with the way they've worded things. But basically, when you do that monofilament test, you're checking for what's called the sort of sensory protection of the foot. If there's been a loss of that sensory protection, that is basically if on the plantar surface of the foot, you've lost one of these 9 places. So just one of those is a loss of protective sensation. The less than 8 sites and the greater than 8 sites, my brain can't process what that sentence means. No feeling in less than 8 sites. But I looked it up in another guideline, and basically say 8 of these were positive and 1 didn't have feeling. That's enough to upgrade them from low risk to increased risk. The difference then between increased risk and high risk is whether there's skin changes. An emergency is when there's an infection or an ulcer. The lower limb examination, it's a problematic OSCE station in the past, but basically just make it up as you go. Be systematic. Inspect, palpate, auscultate, and then get them to do special movements. In terms of inspection, look at the skin. Look for ulcers, amputation, redness, varicose veins, venous staining, loss of hair, scars. Just look at the leg and comment on anything that could be in terms of skin, blood flow, or injury, an issue. Then palpate. Check for temperature. Temperature tells you how the blood flow is going. Check for peripheral edema. That tells you how the venous drainage is going. Check for capillary refill. Tells you how the little arterial capillaries are going. Check for calf tenderness, and then check the pulses. Popliteal, posterior tibial, and dorsalis pedis. You might not feel the popliteal pulse because it's very tricky, but if you practice the posterior tibial and dorsalis pedis on yourself, they're actually very easy. For dorsalis pedis, that one's typically okay, but for posterior tibial, I had a lot of trouble with that. The trick is basically if you stretch your foot up, so dorsiflex it, so your toes are going to the roof, so it's really stretched, and then go from the sort of corner of your heel to your medial malleolus, go about halfway while it's stretched and just feel around in that area, going sort of up and down in a diagonal line, and the pulse is typically there. It's sort of further away from the malleolus than you'd expect. Auscultate, you could probably skip this in an OSCE and it'd be fine, but you're checking the abdominal aorta and the renal arteries to see if there's, signs of a big atherosclerotic lesion in the abdominal aorta, which has thrown off clots into the arteries going to the feet, leading to your limb ischemia. So you might hear a bruit because of that. Check the sensation. Use your fine touch, your sort of gross, cotton wool touch. Do vibration and proprioception, and then use the monofilament on the bottom of the foot if they're diabetic. Then get them to move all the joints, and that's kind of it. You could test for coordination as well if you want, but that's more of a brain thing, not really a limb thing. Let's talk about the management of diabetes. So first and foremost, I moved this slide to the beginning. Lifestyle management is a priority in diabetes care. In the same way that, the first thing you do for depression is therapy, not SSRI, goodbye, it's lifestyle management. So diet and exercise. There's lots of debate about what the best diet is, but basically a diet that's rich in whole foods, lots of different vegetables, that has a tailored total caloric intake to promote weight loss if they're overweight, or at least, a steady maintenance weight if they're not overweight, with plenty of fruit and vegetables. There's no need to reduce fruit. Just because diabetics have high blood sugar doesn't mean that they can't eat sugar. It's a symptom of the disease. It doesn't mean that sugar itself causes insulin resistance. It's insulin resistance that causes hyperglycemia. So, a diabetic can eat watermelon and it's fine. And the idea that, sugar is the main thing causing insulin issues is crazy, because protein also requires insulin to be anabolically activated. And there is a very interesting study showing that, per sort of gram of protein, a steak and white potatoes, a steak actually causes more insulin release per gram than white potatoes, because protein requires insulin as well. Fat is the only thing that doesn't need insulin. So, you can cut out sugar all you want, but anytime you eat meat or any protein, you're stimulating insulin as well. So the idea that, sugar is bad is missing the point, I think. Calories are bad. Eating excess calories for, a chronic period of time combined with inactivity and some genetic predisposition, that's how diabetes happens. Not from eating watermelon. Physical activity itself can cause insulin-independent uptake of glucose to improve glycemic control, but now they're also finding that, it can actually improve the ability of the skeletal muscle to react to insulin. So you can actually reverse insulin resistance through a diet and exercise program. So this area is constantly evolving, and, some people are very nihilistic and they say, oh, look, it's impossible to get my patients to lose weight and exercise. It's just not going to happen. This is all pseudoscience. I'm just going to ignore it. But I think, the motivational interviewing approach, given in a genuine, empathetic way to someone who wants to listen, we should tell them the truth, that if they go hard on the diet and exercise and do it right, there's a good chance that they could really change their life. It's not really up to the doctor to say, oh, I don't think my patient would be willing to do that. It's up to the patient to listen, and we should at least try. With that big long rant out of the way, let's talk about drugs. Here's the best guideline for diabetes, the Royal College of GP's Diabetes Management Guideline. On the front cover is a French lilac, which is the plant from which biguanides are derived, which metformin is a biguanide. And here's their guideline for type 2 diabetes. First line is metformin. You start at 500 milligrams, you go up to 1 gram. If they've got bad kidneys, you stay at 1 gram. If they've got good kidneys, you go up to 1 gram twice a day. Easy. If after, say, 3 months, metformin isn't, doing anything for you, the HbA1c hasn't really changed, the best you'll get out of metformin is sort of 0.5 to 1%. So if their HbA1c is like 9%, you might even start with 2 agents straight off the bat. But anyway, if you're not achieving the target with metformin alone, you can add a second agent. The most common second agent is a sulfonylurea, something like glibenclamide. Sulfonylureas have a risk of hypoglycemia, shouldn't be used in the elderly, but they're cheap and effective, so they're still very commonly used. And I met someone that was 75 the other day whose GP still had them on a sulfonylurea. They were in the hospital with hypoglycemia. So, yeah. DPP-4 inhibitors and SGLT2 inhibitors. DPP-4 inhibitors are things like sitagliptin, linagliptin. SGLT2 inhibitors are things like empagliflozin. Both are great. SGLT2 inhibitors in a recent trial showed protective effects on the kidney and the heart. We'll see where the evidence goes with that, but I think people are really keen on SGLT2 inhibitors at the moment. So then if you combine those two drugs and they're still not working, you can combine a third drug. So whatever drug you didn't add, you can now add the other one. Or now that you're up to a third line therapy, you could add a GLP-1 receptor agonist. So something like exenatide, which is actually a subcutaneous injection. All the GLP-1 analogs are injectables. So that's something that you need to consider in terms of tolerance and ongoing, whether the person's going to take it or not. So, you could combine a DPP-4, an SGLT2, and metformin. That would be a reasonable combination. Or at this point, if you think it's therapeutically appropriate and the person is willing, you can try insulin. If, you're on these 3 drugs and now things still aren't working, you go to this final line of change one of the agents to be a GLP-1 receptor agonist or insulin, or another oral agent. And if you're already on a GLP-1 receptor agonist and it's not working for you, so that was one of your third line choices, you can change it to insulin. And if you're already on insulin, you can add a different drug. You can add a receptor agonist, or you can add a new plan that is sort of similar to how type 1 diabetes is managed and do basal bolus insulin. And we'll talk about insulin a little bit later. So to make this simple, 1, metformin, 2, something else, sulfonylurea, SGLT2, or DPP-4. Step 3, consider insulin. That's sort of the simple way of looking at it. And at the same time, maybe consider something like exenatide, the GLP-1 analog. But remember that it's injectable. And you'll notice that thiazolidinediones and acarbose were never highlighted in blue. So these drugs exist, but only the things that are blue are what are recommended by evidence. So I think these two are going to disappear. Thiazolidinediones are contraindicated in heart failure, just as a random fact. So metformin, the way it works is it prevents the liver from making sugar, it prevents intestinal absorption of sugar, and it makes your peripheral tissues more sensitive to insulin in order to promote glucose uptake. It's derived from the French lilac, which is the cover of the guideline. If you've got bad kidneys, you need to adjust the dose, so you only go to 1 gram max dose. And that's because you can increase the risk of lactic acidosis, which is a very rare association, but the risk of it is higher in bad kidneys, and also higher when giving contrast for imaging. So when you order a CT scan with contrast, they'll ask you if the person's on metformin or not. It causes malabsorption of B12, so you should monitor their full blood count and give IM B12, 6 monthly, yearly, whatever. And the most common side effects are GI side effects, nausea, vomiting, diarrhea. You can mitigate that by giving metformin controlled release preparations. It's still the same dose, but it's a sort of extended release. And it means that you can give metformin despite having sort of poor GI tolerance. If the extended release is still not tolerated, then you need to sort of rethink things, because metformin is an awesome drug, and I think even with some nausea, you might try and push through it and see if, with drinking lots of fluids and having a regular routine, if maybe that nausea could be mitigated while still taking metformin. It doesn't cause hypoglycemia, and it helps you lose weight and reduces your appetite. Sulfonylureas are things like glibenclamide, gliclazide. It makes potassium stay inside the pancreatic cells, which depolarizes them and causes the release of insulin. So even when your glucose hasn't touched the pancreas, you tell the pancreas to release insulin. That's where the risk of hypoglycemia happens, is if your glucose is low, normally your pancreas wouldn't dare to release insulin. But with sulfonylureas, they'll force it to release it. So you could have a blood sugar of 4, take your daily glibenclamide, which is a long-acting sulfonylurea, and crash down to 2 and, be very unwell. So don't use it in the elderly. Glibenclamide is available combined with metformin as glucovance. And the issue there is, if someone's used to taking metformin, taking 3 tablets, 2 tablets, doesn't really matter. But if you then give them glucovance and you titrate it to a certain sulfonylurea daily dose, it'd be not good if they were like, oh, I'm going to take an extra metformin today because I'm eating cake or something, and then they've overdosed on sulfonylurea because they didn't know it was in the glucovance. They're associated with weight gain. That's a big negative for sulfonylureas, as well as the risk of hypos. DPP-4 inhibitors like sitagliptin or linagliptin, they inhibit DPP-4, which increases GLP-1, which promotes glucose-dependent insulin secretion. So they don't really cause hypos on their own because they're just making the pancreas better at doing its job. So if the glucose is low, the pancreas won't release any insulin, but when the glucose is high, the GLP-1 will help the pancreas to release insulin properly. If you combine it with a sulfonylurea or insulin, it can make hypoglycemia worse, and this is because DPP-4 inhibitors reduce glucagon synthesis, which means there's no stimulus for the liver to produce glucose. So if the sulfonylurea drops your glucose, you'll then dampen the response via glucagon. It can be combined with metformin as Genumet, which is available on the PBS, and it's beneficial for weight loss. One other random thing I learned today is that a version of the DPP-4 inhibitors, which is linagliptin, it can be used in people with renal failure, whereas sitagliptin has to be dose adjusted. And so most commonly, if people are on linagliptin, it's because they have chronic kidney disease. Here's just a diagram of, the DPP-4 enzyme breaks down the incretins, which include GLP-1. DPP-4 inhibitors block that to increase GLP-1, which promotes insulin and reduces glucagon and causes a lowering of blood glucose. SGLT2 inhibitors, the gliflozins such as empagliflozin, it blocks SGLT2, preventing the reabsorption of sugar and sodium in the kidney, so you pee out sugar. There's a really important adverse effect, which is euglycemic ketoacidosis. So even with normal blood sugar, these people for some reason can go into ketoacidosis. That's really scary. And even more scary is perineal necrotizing fasciitis, or Fournier's gangrene, which is a necrotizing gangrene of the perineum, which is your genital area. That's really bad. As well as that, because you've got more sugar in your urine, you're predisposed to urinary tract infections, genital candida, and a diuretic effect, which will cause, low blood volume, potentially hypotension, postural hypotension, syncope, so on. But they're very protective against, heart failure and chronic kidney disease. They maintain heart and kidney function because of multiple reasons, and they can actually directly reduce albuminuria, which is one of those markers that if someone goes from intermittent albuminuria, so every so often they pee out a bit of protein, to persistent albuminuria, it means that within 5 to 10 years they're going to be in end-stage renal failure and need dialysis. But these drugs seem to reduce the onset of persistent albuminuria. So maybe they can delay the time from diagnosis to needing dialysis, and that would be incredible. When I was on neurology, one of the consultants randomly pimped me and said, "Oh, what's the name of the trial that showed that they were renoprotective?" You shouldn't know that. Consultants ask you insane questions, but turns out that it's the EMPA-REG outcome trial. And because that was such a weird question, I'm going to remember that forever now. Thiazolidinediones, which I think are just going to be phased out, include pioglitazone. They're an agonist against peroxisome proliferator activator receptor gamma, PPAR-Y, and that is a gene that controls a family of genes that regulate lipid and glucose metabolism. You should recall that fibrates, like fenofibrate, managing high triglycerides and cholesterol, they also interact with the PPAR family of receptors. The thiazolidinediones increase peripheral sensitivity to insulin, and they reduce hepatic gluconeogenesis through complex mechanisms. But they cause fluid retention, and they can worsen heart failure, and they're associated with weight gain. GLP-1 analogs like exenatide, they're a subcutaneous injectable, and basically they do the same thing as DPP-4 inhibitors, but they actually do it a little bit better. So they increase the secretion of insulin, they reduce glucagon, and they actually slow down gastric emptying, which prevents those hyperglycemic spikes when you eat because your food is more slowly absorbed. And they promote weight loss. I just wanted to give a brief overview of the different types of insulin. You don't have to remember this for your exams, but all the doctors in the hospital next year will for some reason expect you to know it. The ones that I've seen in the hospital are NovaRapid and Humalog, and they are the short-acting insulins. So they're the ones that you give at the time of a meal, and they just give a little spike of insulin that's enough to help absorb the extra carbohydrates and protein coming from that meal. So NovaRapid is very commonly used. In terms of long-acting insulin, the most common long-acting one is insulin glargine, which is opticillin, previously known as Lantus. Everyone knows the brand name Lantus. They did an incredible marketing campaign, I guess, and they were the dominant brand forever. They are long-acting insulins, including this protophane Inallet, which is one that I've seen used a lot for gestational diabetes. These are what you take either in the morning or at night, and they can last, 12 to 24 hours, they give you a basal insulin. They hang around for the whole day, and that's kind of your baseline insulin that just constantly keeps you going. So you've got that basal insulin, and every time you eat, you add a little bolus of a fast-acting, short-lasting insulin, such as NovaRapid or Humalog. That's what basal bolus dosing is. So you've got your basal insulin and then boluses with each meal. This is an attempt to mimic what the pancreas normally does. On this final area of the table, these are mixed insulins. It's a combination of sort of medium-acting and long-acting, or short-acting and long-acting, intermediate, so on. They're basically designed that you can take them twice a day, and they give you the same effect as basal bolus, just instead of having, one injection of basal and then 3 injections of bolus, sometimes 4, you just have to stab yourself twice. In the hospital, they typically do the basal bolus. In the community, I'm sure these things are more popular. Shock is something that you should understand quite well by the end of first year. And you need to sort of think about it in terms of blood, the heart, and the blood vessels. So blood refers to having low blood volume, which can be because it's depleted, because it's being shunted somewhere else. For example, in the nephrotic syndrome case where you've got low albumin, you then get ascites and edema. So all of that water that should be making up your blood volume is floating around in your peritoneum as ascites. So you've got low volume in your blood. Hemorrhage or GI or urinary losses. Someone with chronic diarrhea will be in shock. Cardiogenic shock is when the actual heart is failing to pump that blood, and that can either be because it's in an arrhythmia that reduces its efficiency of contraction, or it could be an acute heart attack, or a cardiomyopathy, or pericarditis, for example. If it's the CONstrictive pericarditis. Then you have distributive shock, which basically for us includes sepsis and anaphylaxis. The cause of the drop in blood pressure is a vasodilation of the body's blood vessels. The distribution of blood has changed. So, that's the whole purpose of using adrenaline in anaphylaxis, to get those vessels constricted. So remember, mean arterial pressure equals cardiac output times total peripheral resistance. Distributive shock is when the total peripheral resistance goes really low. Cardiogenic shock is when the cardiac output goes really low, either because of a reduced stroke volume or a reduced heart rate, or both. Hypovolemic shock is because of a reduced stroke volume secondary to reduced venous return. And then obstructive shock is like when something is blocking blood from going into or out of the heart. So tension pneumothorax, cardiac tamponade, or a really big pulmonary embolism. If there's a big pulmonary embolism in the pulmonary artery, then the right ventricle is no longer pumping. There will then be very poor blood going back to the left atrium, so then the left ventricle will have hardly anything to pump, and that will cause obstructive shock. Vascular disease is something to just have a rough idea of, that there's arterial disease and then there's venous disease. In terms of arterial disease, the peripheries will be cold and pale. They'll get claudication, which is that sort of, basically it's kind of like angina, but for your peripheral muscles. For example, your calves getting sore after walking, not a long distance. And then arterial ulcers, which have a punched out appearance. They look quite different compared to venous ulcers. Also, the legs will appear shiny and they will have no hair on them. That's another feature of arterial disease. And they're at a high risk of having coronary artery disease because, the popliteal artery affected in peripheral artery disease is big. So if that has atherosclerosis, then I guarantee you that their tiny little LAD will also have coronary artery disease, atherosclerosis going on in it. Venous insufficiency, that sort of has this process of venous eczema where you get a scaly hemosiderin-stained swollen lower limb that can have varicose veins, and you can have venous ulcers, which they look a bit different. They're not punched out. They, you just kind of have to look at pictures to sort of appreciate the difference. Thrombophlebitis is inflammation of a vein after it's been played with by a doctor. And then there's vasculitis, which includes small, medium, and large vessel vasculitis. And there are like so many of those that you need to know one day, but for now you can probably get away without really knowing that many.
All right, so now we're going to discuss blood pressure pharmacology. So this is all from ETG, and I've used the AMH to find any drug reactions. So in terms of general principles for blood pressure pharmacology, of course, you've got your lifestyle factors that you need to take into account, as always, but we won't be discussing these here. We'll discuss specifically the pharmacological interventions. In terms of first line, for blood pressure pharmacology, it's your ACE, your ARBs, your dihydropyridine calcium channel blockers, and your thiazide diuretics. And we'll talk about each of these individually in a minute, but I thought I'd just tell you that these ones are the first line ones. And the choice of either of these is dependent on the patient's comorbidities and the potential adverse effects. And we'll talk about which patients would work best with each of these drugs in a minute. Should we also know that beta blockers are also on this list, but they're used more in heart failure and they're not actually first line in blood pressure control. So they're mostly used for heart failure. So how you prescribe these drugs is you start with a single drug and you review regularly. And obviously that in that review, you find out if the blood pressure is getting under control. And if it's not, you can increase the dose or add another drug. And just as a side note, patients usually require 2 or more drugs to reach their blood pressure target. I've got a list of some good combos. So these are things that are commonly put together. So thiazides with ACEs or ARBs, ACEs or ARBs with calcium channel blockers, beta blockers with your calcium channel blockers, your dihydropyridines, and ACE or ARB with dihydropyridine calcium blocker and a thiazide diuretic. So now we'll talk about each of these individually and discuss what they are, what they do, and what are the potential adverse effects of them. We'll start with your ACEs. So these are, for full name, it's the angiotensin converting enzyme. Essentially, the names of this are captopril, lisinopril, enalapril. Apologies for any of my pronunciation. The key with this one is anything that ends in pril. And so if you see that, it's most likely an ACE. And these work by blocking the angiotensin converting enzyme, and that sort of blocks the conversion of angiotensin 1 to angiotensin 2. And it also inhibits the breakdown of bradykinin. So this essentially works by stopping RAS. When ACEs are useful, they're very useful for heart failure with reduced ejection fraction. They're very useful for kidney disease, so diabetic nephropathy. So ACEs are great for patients with heart failure and with diabetes. They do come with some adverse effects though. So you've got the cough, because there's an inhibition of bradykinin breakdown. You've also got hyperkalemia, you got hypotension, you got headache, and you get angioedema. So these are fairly common side effects, but they are definitely something that you need to monitor for when you put a patient on this drug. Next one is you've got your ARBs, so your angiotensin receptor blockers. These essentially are candesartan, eprosartan, anything that ends in sartan, you're mostly going to think an ARB, so an angiotensin receptor blocker. And this works by competitively blocking the binding of angiotensin 2 to type 1 angiotensin receptors. And that's super confusing. But remember, angiotensin 2 is essentially the end result of RAS, and it works on something called type 1 angiotensin receptors, because there's type 2 angiotensin receptors also, but the ARBs specifically block that. And essentially, again, it's acting very similar to an ACE. It just stops RAS from happening, essentially. These are essentially the same. The reason why you would use an ARB is the same for an ACE. It's just that it does not induce a cough. which is positive for a lot of patients. So they haven't been shown to be better either. So that's why a lot of people still use ACE inhibitors. So that's just something to note, is that they haven't been shown to be better, which is why most people go on an ACE first. And then if it's intolerable, they will switch to an ARB. And they have very similar adverse effects, aside from the cough, as your ACE inhibitors. So now let's talk about your dihydropyridine calcium channel blockers. So some of these amlodipine, clevidipine, anything that ends in pine. I will just flag here, there's another class of calcium channel blockers called non-dihydropyridines, and these are something like verapamil, diltiazem. These essentially, the reason why you have two classes is it actually depends on where they're working at. So your your dihydropyridine calcium channel blockers, these mainly work on arteriolar smooth muscle, meaning your peripheral vasculature. The non-dihydropyridines work on both cardiac and arteriolar smooth muscle, meaning that it works at both a cardiac level and also the peripheral vasculature. So that's something just to flag that why there's two different types. And these essentially block inward current of calcium into cells in vascular smooth muscle, the myocardium or cardiac conduction system. These work on L-type calcium channels in the cardiac conduction system, and essentially just prevent calcium movement into the cells and therefore prevent contraction and prevent the cardiac conduction. The reason why they're really useful is they're very useful for certain cardiac arrhythmias. So this is a certain drug that if you have a patient with hypertension and a potentially some sort of a specific cardiac arrhythmia, you could use this drug. The adverse side effects are hypotension, flushing, and dizziness, particularly the non-dihydropyridines. You need to be careful with them for hypertension. The next class is your thiazide diuretics. One of these is a hydrochlorothiazide. It's really anything with a thiazide at the end. That's most likely going to be a thiazide diuretic. This essentially prevents reabsorption of sodium and chloride in the proximal segment of the distal convoluted tubule. Essentially, it increases potassium and sodium excretion. And the key thing to remember with this is wherever sodium goes, water will follow, meaning that you're going to excrete more water as well. So these are very, very, very useful for edema. So for heart failure or edema of other causes, essentially reduces your vascular volume short-term and long-term induces peripheral vasodilation. So they're very useful for heart failure and for, as I mentioned, and for any sort of edema. The adverse side effect, however, is they can cause hypokalemia because you're getting rid of potassium. They can be diabetogenic because they actually can reduce the vascular volume so much that it actually increases your glucose concentration. And they can also increase uric acid. So for gout, they can be a bit dangerous because you're losing vascular volume, you're going to increase the concentration of uric acid there. And you can also get electrolyte disturbances, as I mentioned, with hypokalemia, and you can also get hyponatremia, so loss of sodium. Next, you've got your beta blockers. As I mentioned, these aren't first line, but they are important in heart failure. And then you've got atenolol or metoprolol, and these are anything with olol is a beta blocker. These competitively block beta receptors in the heart. These to reduce heart rate, blood pressure, cardiac contractility, and reduces conduction speed through the atrioventricular node. To note, you also have beta receptors in your peripheral vascular, your bronchi, your pancreas, uterus, kidney, brain, and liver. They're everywhere. Essentially, they're part of the sympathetic nervous system, and so beta blockers are working to just reduce the sympathetic nervous system. And they're very useful for a post-myocardial infarction, for tachyarrhythmias, so an arrhythmia. Beta blockers are good for specific arrhythmias, and chronic heart failure. So these are useful in that aspect too. The key thing to note here is that you want to get specific beta blockers to the heart, because obviously you can get something like propranolol, which actually works a little bit on the bronchi and can cause sort of bronchoconstriction, which is something you don't want for someone like asthma. So atenolol and metoprolol, these are more specific to the heart. Adverse side effects include hypotension, bradycardia, dizziness, and bronchospasm if it's non-specific, as I mentioned. Now, there's a crap ton of other ones, and we're not going to specifically list out exactly what they do. But I thought it's just interesting to know, so you know that these exist. So obviously you've got your non-dihydropyridine calcium channel blockers, as we were talking about. You got your your potassium-sparing diuretics, something like spironolactone. So this is an aldosterone antagonist. These are quite common sometimes, though. You've got your alpha receptor blockers. So these essentially work, again, like beta blockers, they're working to reduce adrenaline and noradrenaline's influence on the peripheral vascular system. So there's one of note is prazosin. This is actually very useful for men with elevated blood pressure and benign prostatic hypertrophy because they actually cause vasodilation and they dilate the urethra and the vasculature around the prostate. You've also got your centrally acting anti-adrenergic drugs and also your direct acting vasodilators. So these, as I said, the other ones, they're not first line. They're more if the drugs aren't working or your patient is not tolerating the previous blood pressure medications.
The other high yield topic for cardiology is lipids. So let's talk about statins. So they are HMG-CoA reductase inhibitors. For example, simvastatin, rosuvastatin, atorvastatin. They're all like different potency, so the doses are different depending on which brand you're using, and they have different indications depending on how sick the person is. And when I say sick, I mean their absolute risk of cardiovascular events in the near future and their level of cholesterol and whether they've responded to a low potency statin. Because the higher potency you go, the more risk of side effects. They can cause they can chop your LDL in half, reduce your triglycerides, and even increase your HDL, the good cholesterol. So that's an awesome combination of effects. They're broken down by liver, CYP enzymes. So if you're using anything else that inhibits the CYP enzymes, you can get a massive increase in statin level. And one of these things is grapefruit juice. So you need to just be mindful of that sort of liver level interaction. The inhibition of HMG-CoA reductase means that the rate-limiting step in the synthesis of cholesterol is blocked. It also means that a whole bunch of other molecules are no longer produced, which likely contribute to the side effects of statins. And so it blocks the endogenous synthesis of cholesterol by your liver, which then means the liver will have to upregulate its LDL receptors to try and scavenge some LDL from circulation to try and rebuild its LDL within the liver itself. And so that means your liver will take up LDL from the blood. The other effect is that it stabilizes atherosclerotic plaques to prevent plaque rupture. So you can keep someone in that stable angina category and prevent them from ever having plaque rupture with clot formation to stop them getting acute coronary syndrome. Adverse effects are liver derangement and GI upset, and then this sort of musculopathy, a myositis and a rhabdomyolysis, that they're really rare, but they can be more common when combined with fibrates, which is good to know because that's another lipid drug that you might consider adding on. And clarithromycin is a really well-known interaction that can really, really increase the risk of rhabdomyolysis. And I think that's because it's happening at the level of the CYP enzyme in the liver, that the macrolide antibiotic is altering the metabolism of the statin. Cognitive effects with memory impairment may or may not be a real thing. No one is too sure about that. Fibrates. Gemfibrozil, fenofibrate. Fenofibrate's really commonly taken. They are great for triglyceride reduction, but also have other effects, obviously. They bind to this protein called PPARA alpha, to increase lipoprotein lipase, which breaks down triglycerides, but it also has many, many other effects because this is a nuclear response element which binds to the fibrate, kind of like a steroid hormone, and then alters gene transcription to cause multiple effects. So it's not just one thing. The glitazones are PPAR gamma receptor anti-diabetes drugs, which we talked about earlier. So there's this PPAR system that is sort of involved in metabolism in many, many ways to do with fat and sugar. They can cause gallstones and again have a myositis risk, especially if combined with statins. So bile acid binding resins have kind of fallen out of favor. That being said, I have seen someone in the hospital who's on cholestyramine. They can decrease your LDL. They interfere with the absorption of fat-soluble vitamins, so A, D, E, and K, as well as some other drugs. So you need to be mindful of when you're taking tablets at the same time. They are positively charged, and they bind to negatively charged bile acids that get secreted in the bile into the gut. Because of this, that bile will be lost in the feces, and so it's not reuptaken into the liver. Now, bile comes from cholesterol. So in order for the liver to regenerate its bile salts that it normally has from that, gut reabsorption, it'll have to use cholesterol to synthesize new bile acids. So it will need to upregulate its LDL receptor to scavenge LDL from the blood to get the cholesterol it needs to make those new bile acids. Ezetimibe is a smarter version of that doesn't interfere with fat-soluble vitamin absorption. And it can be done in addition to statin therapy, where statins will block endogenous synthesis and ezetimibe will block exogenous reabsorption and absorption from the diet. It blocks the actual pathway by which cholesterol is absorbed in the intestine. So then you don't reuptake your cholesterol from the sort of enterohepatic circulation pathway, but you also don't absorb much cholesterol that you eat. So that will again reduce the liver LDL stores. You'll put up the LDL receptor, and then you'll have to take up LDL from the serum because the amount of cholesterol in the liver is going down. PCSK9 inhibitors are a new drug that it's just, this will probably be a thing in 5 years. Evolocumab and alirocumab, they're not really here in Australia yet, but they are being used in the United States. So what does this protein do? PCSK9, it basically binds to LDL receptors on the surface of liver cells and promotes their breakdown. Okay, so the LDL receptor is the receptor that binds to LDL and lets it be uptaken into the liver cell. And then that LDL receptor gets put back into the cell membrane, recycled. But if that LDL receptor gets bound to PCSK9, it won't be recycled, it will instead be targeted for lysosomal destruction. So in people that have hyperactive PCSK9 from a mutation, they have reduced levels of the LDL receptor on their liver, and so they get high cholesterol. The opposite condition is when the PCSK9 protein is inactive, and so none of their LDL receptors get targeted for destruction. They have a very, very low LDL cholesterol. So that made drug companies think of developing a monoclonal antibody that could block the activity of PCSK9, and that's what these are, and they're given as a subcutaneous injection every 2 to 4 weeks. Other things to think about are niacin and omega-3s. Basically, neither is used anymore, and omega-3s, the evidence is very, very lacking, both for the brain and for the heart. The brain is kind of, maybe DHA is important for brain development and long-term prevention of brain atrophy, but I think the consensus is that omega-3s are neither here nor there. If the person can afford them, then whatever. Maybe they are contaminated with heavy metals from ocean pollution, but ultimately you're not going to stop someone taking it, but you're also not going to push them to take it these days. And it can actually make cholesterol worse, but it can improve triglycerides. Let's talk about antiplatelets and anticoagulation. Firstly, let me remind you that there's a difference between the two. Antiplatelets refer to drugs that block platelets, which is that initial step in clot formation with the platelet plug. Anticoagulants block the proteins of the coagulation cascade to prevent the formation of a fibrin mesh on top of that platelet plug. So these drugs are acting on two separate arms of the clotting pathway. Antiplatelet drugs are drugs that either block enzymes or receptors to prevent platelet activation, aggregation, and to basically stop the platelet plug forming in the first place. If you stop the platelet plug forming, you can then prevent the clot forming because there's nothing for fibrin to stick to. The cyclooxygenase inhibitors, which basically only includes aspirin for the purpose of clotting, that's a widely used drug that's basically used in everything. These days it's only used for secondary prevention of cardiovascular disease because the risk-benefit ratio doesn't look too pretty for primary prevention. There's a higher risk of bleeds for every life that you would save by starting them on aspirin. And the side effects, you can have salicylate toxicity, which can cause hearing impairment, which is reversible eventually, GI upset, and then bleeds. Ulcers and gastric bleeds and intracranial bleeds are worth talking about. The P2Y12 receptor antagonists, or ADP receptor antagonists, they are things like clopidogrel, prasugrel, and ticagrelor. They all have different use cases, right? And some of them are kind of prodrugs and then other ones aren't. And we won't talk about that here, but basically clopidogrel is very widely used and it's actually got a better risk-benefit profile than aspirin. So these days there's this thing of, the dual antiplatelet therapy followed by lifelong monotherapy, which used to be lifelong aspirin because everyone takes aspirin. But there's actually a push now that it should be lifelong clopidogrel because it's got the same benefits with less risks. But yeah, prasugrel and ticagrelor have their use cases depending on comorbidities and things like that. Glycoprotein 2B3A receptors, abciximab doesn't exist anymore, and I'm sad about that because it's the only drug that I can remember, but it's because the manufacturer stopped making it or something. There's some Canadian company, and I just saw one day when I went to study that it just disappeared from the AMH, and when I looked it up, it just said the manufacturer has discontinued it. They block the 2B3A receptor, and they were really popular when PCI was first coming about. And so there's still this indication of like a high-risk patient undergoing PCI. But these days, they've kind of fallen out of favor, and most people get the cocktail of, heparin, aspirin, clopidogrel, or prasugrel, or ticagrelor, followed by PCI, and then lifelong clopidogrel or aspirin or whatever. They don't so much use, tirofiban anymore. Here's just a diagram putting all of that together. So you've got your ADP receptor, you've got the glycoprotein 2B3A receptor, you've got cyclooxygenase through which thromboxane A2 is produced, which promotes platelet aggregation. You need that ADP receptor to bind to ADP that gets released from activated platelets. So all of that together can prevent platelets from sticking together, and it will stop platelet plug formation. Anticoagulants, on the other hand, are drugs that interfere with the clotting cascade. So heparin. Heparin activates an enzyme called antithrombin 3, which then inhibits factors 2 and 10. And that will prevent the conversion of fibrinogen to fibrin, stopping the clotting cascade from forming the fibrin mesh. Low molecular weight heparin has the benefit of being an easy subcut injection, whereas heparin has all these other you need to take daily levels of its activity and you need to titrate it, whereas low molecular weight heparin in the hospital we can just go, oh yep, put this person on VTE prophylaxis, give them 40 milligrams of Clexane subcut daily, and that's it. You don't have to think about it. The negative is that it's really hard to reverse it if the person has a bleed, whereas heparin can be easily reversed using protamine sulfate. The activity of low molecular weight heparin is that it also activates antithrombin 3, but it mainly acts on factor 10, not so much on factor 2. But the reality of that is that it doesn't really make a difference. Therapeutic clexane and therapeutic heparin do the same stuff, more or less. The difference in terms of clinical stuff is that low molecular weight heparin, you need good kidney function to use it, whereas unfractionated heparin is independent of renal function. Now, the point there, though, is that in people with a creatinine clearance of less than 30, there's a dose adjustment that can be done of low molecular weight heparin. But then you don't really know the efficacy because you're giving a lower dose that, do you really know how much the renal function is, retaining that drug to make it equivalent to the full dose in a person with normal renal function? So people with poor renal function, you'll opt for unfractionated heparin or warfarin. Warfarin is great. DOACs and warfarin. So these are drugs that act on factor 2 or factor 10, the DOACs at least. Dabigatran, apixaban, rivaroxaban, they're sort of the most commonly used ones in practice. The studies show that they're all equal for now. But I know sort of dabigatran is falling out of favor by the neurologists on the stroke unit because I was there. The direct thrombin inhibitors, they block factor 2A, and the factor 10A inhibitors, they block factor 10A. They have XA in their name, not fondaparinux, but rivaroxaban XA, apixaban XA. These are oral tablets that you take, and they are, it means that you don't have to inject yourself with clexane, but you get all the benefits of warfarin without having to have INR monitoring. It's kind of the future of anticoagulation. It, of course, has its negatives, so these again rely on kidney function, body weight, and age in terms of how good they are, and they have less reversibility generally than warfarin, which can be reversed quite easily with prothrombin and vitamin K. So there's always pluses and minuses with these things, and also these things don't get regularly monitored with blood tests. So, an argument against warfarin is that you have to go and get blood tests and get your INR checked. But an argument for warfarin is that you have to go and get blood tests and get your INR checked. So if you've overdosed or underdosed, you know about it. Whereas with these drugs, I've seen people on apixaban that go on to have a stroke, and all we can do is say, oh, okay, let's try you on rivaroxaban then, I guess. Whereas with warfarin, if you look at their INR and it's 2.5, they're not going to have a stroke, Obviously, I can't guarantee that, I'm sure it still happens, but that their blood is water at that point. You've seen it in a test. That it's true. So you can trust it. Whereas these drugs, depending on their renal excretion and metabolism and the person's body weight and the volume of distribution, you just don't know whether it's actually working sometimes. So that's why some old school doctors will push for warfarin. So warfarin is a vitamin K antagonist that interferes with the production of factors 2, 7, 9, and 10. The way I remember that is insane. It's 2 plus 7 equals 9, plus 1 is 10, 2, 7, 9, and 10. The parasympathetic cranial nerves are 3, 7, 9, and 10, which is just the vitamin K factors, but instead of 2, it's 3. So those are just 4 numbers that I remember from medical school really well. 2, 7, 9, and 10, and then 3, 7, 9, and 10, because we were doing anatomy and the PBL case on heart attack and whatever at the same time. So 2 plus 7 equals 9, plus 1 is 10. 2, 7, 9, 10. It's the channels on the TV apparently, but I don't really remember that too well. What's channel 2? I haven't heard of that. So warfarin is amazing, and specifically in people that have atrial fibrillation who have a heart valve, they need to be on warfarin. People with atrial fibrillation who don't have a heart valve, they can go for these DOACs. And in theory, the DOACs and warfarin are equally efficacious. It's just there haven't been any studies on people with heart valves. They were excluded from the trials that were used to assess DOACs for atrial fibrillation. So, anticoagulants. Put together, we have, all the pathways. We have the vitamin K antagonists, which is warfarin. We have DOACs, which can either be 10A or 2 inhibitors. And then we have heparin. Okay? So add that to your antiplatelets and you understand everything you need to know about blood thinning and prevention of clots. Fibrinolytics are drugs, also known as thrombolytics, that bust clots. They actually force the clot to break down. The original drug here that isn't listed is streptokinase, which is fallen out of favor because it, once you've used it once, the body mounts an immune response to it and you can't use it again. And it doesn't work in Aboriginal people who've had rheumatic heart disease because the antibodies to streptolysin, which is a strep antigen, they also interact with streptokinase, but whatever. Alteplase I see used a lot. These drugs, they activate tissue plasminogen activator to promote the conversion of plasminogen to plasmin, which then catalyzes the breakdown of fibrin. So it forces clots to break down. So you can use it in an ischemic stroke in the early phases, sort of roughly 4 to 6 hours, 4 hours we'll say. In a heart attack, in a massive PE that's got hemodynamic compromise. But the thing to take away from this is that if a clot isn't causing harm, you could just give the person heparin, which would prevent the clot from getting any bigger, and then wait for their body to break it down on its own. By giving a fibrinolytic, you're making an active choice to dissolve that clot, which puts them at significant risk of bleeding from the brain and gut, which could kill them. Which is why it's only used in a pulmonary embolism that's associated with shock, because otherwise you can just give them heparin and wait for that pulmonary embolism to break down on its own. It won't kill them. But if it's so big that it's causing shock, then yeah, you need to dissolve that thing to cure the shock. So here's just a diagram showing that it promotes the tissue plasminogen activator to turn plasminogen into plasmin, which will then break down the fibrin mesh and destroy the clot. Anti-arrhythmic drugs. We're not going to talk about these in detail, but I just want you to be aware that there are 4 classes of drugs. Class 1, they block sodium channels. Lidocaine, the local anesthetic, is a class 1 antiarrhythmic. Class 2 is beta blockers. Class 3 is potassium channel blockers. And class 4 is calcium channel blockers. That's all I really want you to know, and then if you line it up with the cardiomyocyte action potential, you can see how this can alter the sort of excitability of the heart. These drugs are basically the same thing as anti-epileptics in the brain, right? They prevent the heart from firing too often to reduce arrhythmia. So it can either be sodium preventing that initial depolarization, calcium altering the length of that depolarization, potassium delaying repolarization, and beta blockers too. So just that's all you need to know at your level. Some of the most commonly used ones are, if someone's in ventricular tachycardia, you can use procainamide or amiodarone. If someone has AF, you could use amiodarone as a rhythm conversion, or flecainide. And then obviously beta blockers control the rate more so than they do the rhythm, so they just slow the heart. But they are an antiarrhythmic used at a certain strategy. Well done on making it through all of that content. The next section, I'd like to talk about some cardiology cases just to tie everything together to presentations, which will help in OSCEs in the future. So this is all based on a book called Problem-Based Cardiology Cases by a cardiologist at Gold Coast Hospital, Dr. Rahman, and also his colleague, Dr. O'Connor from Melbourne, I believe. So full credit to these guys. None of this is really my own ideas. These are cases from their book. So I want to talk about some complaints first. So dyspnea. The patient has dyspnea, and the OSCE station would say, she's a 34-year-old female with increasing dyspnea. Take a history and provide some differential diagnoses. So the history is that she's 34 years old, she's had 2 weeks of shortness of breath, she has difficulty lying flat in bed, and she wakes up frequently short of breath. She has a dry cough and she's extremely tired, but she also has a fever. And on social history, you discover that she regularly uses IV drugs. And the GP who sent her to the hospital has noted the presence of a new murmur on cardiovascular examination. So then you examine the patient, and on inspection you note that they are breathing very fast, that there's lots of pillows on their bed, and they have a dry cough. When you look at their hands, on their fingernails you note splinter hemorrhages. You see Osler's nodes on the fingers and Janeway lesions on the palms. The Osler's nodes are painful to touch, but the Janeway lesions are not. On their arms, in their flexor crease of the elbow, you see track marks from where they've injected with intravenous drugs. Listening to the chest, you hear a systolic murmur that's loudest in the 5th intercostal space of the mid-axillary line, and it radiates to the axilla. You hear it best with the bell of your stethoscope, and it's loudest when the person lays on their left side. On the back of their chest, they have bibasal fine crepitations, which sound kind of like, rice pops being crushed. The conclusion of this is that the patient, from IV drug use, has got bacterial endocarditis, which has vegetated on their mitral valve in this case, causing acute mitral regurgitation, which has led to blood going from the left ventricle up into the left atrium during systole, causing pulmonary vein congestion, causing pulmonary edema, leading to their shortness of breath, which gets worse when they lay flat because gravity will allow that fluid to disperse itself across the upper, middle, and lower lung zones, whereas when they sit up, the fluid will collect in the bases. That fluid being present in the bases, as you breathe in, the alveoli try to open against this fluid, and that creates the popping sound of the crepitation. And so putting all of that together, you decide that this person has left-sided heart failure due to acute mitral regurgitation, secondary to infective endocarditis, leading to their shortness of breath complaint. Chest pain. A 68-year-old female comes into ED with severe intermittent chest pain. It started 4 hours ago, and her background history is that she's been a lifelong smoker with high blood pressure. The initial examination and ECG are unremarkable, and she's actually currently pain-free. But they decided to keep her in ED because it was quite concerning for cardiac chest pain. She had another episode of chest pain while she was hooked up to the ECG, and it showed ST depression in leads 2, 3, and AVF, and her serial troponin was actually elevated at this time. So they gave her dual antiplatelets, aspirin and ticagrelor, as well as low-weight molecular heparin, enoxaparin, and they also started her on a statin and a beta blocker. So note that this is an NSTEMI, so they don't need like an immediate reperfusion strategy, but they went for coronary angiography, which showed that the RCA was 90% narrowed with 50% narrowing of the LAD. And so then later they did a dilation with stenting of the RCA with a drug-eluting stent, and they got her to quit smoking. and this effectively resolved her chest pain, which, she basically had an N-STEMI in this case. Her initial presentation would have been consistent with unstable angina, but the findings of ECG changes suggest that this is an N-STEMI. So what are the causes of chest pain that can kill someone? Well, as an intern, you'll be called to the ward all the time for someone who has new chest pain. The things you need to rule out are acute coronary syndrome, aortic dissection, pulmonary embolism, tension pneumothorax, and ruptured esophagus, because these are the things that can rapidly kill. In the acute coronary syndrome, the patient will be diaphoretic with crushing retrosternal chest pain radiating to the jaw and the arm with an impending sense of doom. There'll be, if it's N-STEMI or STEMI, there'll be a troponin rise with ECG changes. In an aortic dissection, there will be a sudden and severe tearing pain that radiates to the back, and there might be a blood pressure difference in the left versus the right arm. In pulmonary embolism, there'll be a pleuritic chest pain, so it's worse on inspiration, with shortness of breath, cough, and coughing up blood, hemoptysis. Tension pneumo will be a sudden onset, localized to the side of the pneumothorax. There'll be pleuritic pain because the pleura is being interfered with shortness of breath and distended neck veins if it's causing obstructive cardiac shock. There'll be reduced breath sounds on the side of the pneumothorax. It will be hyperresonant to percussion because you're basically tapping on a hollow chamber because the lung is collapsed. And there'll be reduced chest expansion. In ruptured esophagus, typically someone will have severe vomiting or retching, and then suddenly their chest will be in severe pain. And what often happens there is that the esophageal sphincter is closed, and the person's stomach tries to forcefully vomit against that, and that rips the esophagus. And there's two conditions to know there. There's a Mallory-Weiss tear, which is just the rip of a few layers of the esophagus, and then Boerhaave syndrome, when the actual esophagus ruptures entirely and you have air within the mediastinum and gastric contents in the mediastinum, which can be rapidly fatal. The things you need to be careful of are women, old people, and people with dementia and diabetes, because their chest pain might not look like a heart attack, but it actually is a heart attack. A 75-year-old female comes to the GP with palpitations, weakness, decreased exercise tolerance, and shortness of breath. On examination, you note that when feeling her radial pulse, it's irregularly irregular. Her past medical history has high blood pressure, diabetes, and a stroke 2 years ago, which was an ischemic stroke. So what are the causes of an irregular pulse? The most common would be atrial fibrillation. But if you think about second-degree heart block, every so often you're going to be dropping a heartbeat. So when you're palpating someone's pulse, that would be irregularly irregular, depending on which kind of heart block it is. If someone's having ectopic beats, there'll typically be a pause after that ectopic beat, so the pulse again will be irregular because of the ectopics occurring. Atrial flutter with variable block, again, so you'll get a certain number of flutter waves and then a QRS. That, if that ranges in the block, whether it's, 2 flutter waves for each QRS and then 4 for each QRS and then 3 and so on, that'll give you an irregular pulse. And then sinus arrhythmia is another differential. This is her ECG, and you've seen this earlier. So there are no P waves and the RR interval is irregular. So this is a non-sinus rhythm. The RR interval is irregular, so it's an arrhythmia. This is atrial fibrillation, and you can see fibrillation waves in V1, and you can see quite a few little lumps between the RR interval. So what causes AF? Well, the reason that you should care about it is because it means that there's typically an underlying cardiovascular disease going on or a systemic condition. Ischemic heart disease is the most common cause, but also high blood pressure, valve disease, sepsis and acute infections, electrolyte issues, hyperthyroidism, medications, acid-base disorders, and many, many other things. It's basically just what happens when the body's stressed, is that the electrical conduction in the atrium becomes a bit upset. How do you treat it? Firstly, there are two arms to this. You can control the heart rate or the heart rhythm, and large studies demonstrate that there's no real difference between the two in terms of positive effect, so both of them are good for you. But rhythm control is associated with more negative outcomes because of the side effects of antiarrhythmic drugs, which are quite dirty drugs, like I would rather put someone on a beta blocker than amiodarone. That may change one day when they have better designed studies, and there's some suggestion that in people with atrial fibrillation and heart failure at the same time, restoring sinus rhythm with, a rhythm control strategy with amiodarone might actually have some mortality benefit. But the official position from the Cardiology Society is that there is no difference between rate and rhythm. It's just rhythm has more negative side effects. Electrical cardioversion can be done. There's certain, timelines for that based on the chance of whether or not there's a clot in the heart. And then catheter ablation, I'll show on another slide. Interestingly, the prognosis of people with AF and heart failure at the same time is better if they have catheter ablation compared to rate or medical rhythm control. So that tells you that because catheter ablation is a method of restoring sinus rhythm, that restoring sinus rhythm might actually have some positives over rate control. And maybe the drug studies that compared rate to rhythm control weren't designed well enough to be able to pick up that difference. It's possible. I'm sure there'll be more research to come. And then the second most important thing, or the most important in terms of survival, is anticoagulation, because their risk of cardioembolic stroke is really high. And it's that CHADS-VAS score we talked about, or a CHADS-VAR score in Australia. So they removed the SC, which was sex category. These are the most recent Australian guidelines, I think from 2018. So C, congestive heart failure, hypertension, age over 65, diabetes, stroke, which you get 2 points for, vascular disease, and then age over 75, you get 2 points for. If you get one or more, then you need anticoagulation. And it can be done with NOACs or DOACs or warfarin. The NOACs, you can't have any valvular disease though, because the studies didn't include those people when they assessed the efficacy of NOACs for AF anticoagulation. Here's catheter ablation, which is just the coolest thing in the world. So the anatomical basis for atrial fibrillation, the theory is that the arrhythmia arises around the pulmonary veins. Okay, it's got something to do with the pulmonary veins. So they insert these catheter wires and they actually burn little circles around the annulus of the pulmonary vein to try and prevent that, bad electricity basically from being transmitted into the rest of the heart. So you can effectively, cure atrial fibrillation by burning these holes to prevent the fibrillatory signal from being sent to the rest of the heart. Syncope. This is something that you work up all the time on Gen Med. So we've got a 23-year-old female presented at ED after a brief loss of consciousness. She's had 4 previous episodes in the past 2 years. She was sweaty, nauseous, and looked pale before she collapsed. How do you classify syncope? So it can be neural, orthostatic, or cardiac, basically. The neural causes are vasovagal, which is that massive parasympathetic outflow, which drops your cardiac output and makes you collapse for a while until you get a rebound tachycardia to restore consciousness. Situational, so some people get micturition syncope, where they pee and then pass out. or this carotid sinus syndrome, which is, doesn't matter. Orthostatic hypotension is basically when someone has low blood volume and then they stand up too quickly, and then because of the low volume, they can't compensate for the effect of gravity. So there's not enough force to increase cardiac output to get blood flowing to the brain when you stand up. So that can either be, from over diuresis with, too much furosemide, or someone who's dehydrated. So that's orthostatic hypotension, and it's positional. It's going from lying to standing. So you can do lying and standing blood pressures on these people to prove that they have orthostatic hypotension, as well as, check their heart rate lying and standing. Cardiac syncope is when you've got those bradyarrhythmias, tachyarrhythmias, or genetic arrhythmias. So that includes long QT and Brugada syndrome. Long QT is a good one to really know about because you can go in and out of torsades, which would then make you pass out, and if you don't catch it, these people will die. And then structural heart disease. So aortic stenosis is a very common cause of syncope in elderly people. You could be having a heart attack. You could have hypertrophic cardiomyopathy, obstructive cardiomyopathy. That should be HOCM, or something like cardiac tamponade. And then the sort of other things that are not syncopal are seizures, strokes, and low blood pressure, and this interesting thing called subclavian steal syndrome, which is when you have stenosis, either from atherosclerosis or some congenital defect of the subclavian artery. And so to get blood supply to your arm, you actually suck blood from the brain, reversing the flow in the vertebral artery to get that blood into your arm. That's subclavian steal syndrome. And that will then reduce blood flow to the brain and lead to syncope. Good luck in your exams.